Good morning, everybody. We're going to go ahead and start. Good morning. My name is Dr. Esther Kim, and I am a cardiologist and a vascular medicine specialist. And now, as of October, I am the director of the Center for Women's Cardiovascular Health here at Atrium Health, Sanger Heart and Vascular Institute. And I've been a long time member of the scientific advisory board for SCAD Alliance. And over the past, I think, 10 years, taking care of patients and helping to advance the science of SCAD has been my passion. And I'm so happy to welcome you here today. We may complain that it's raining and that it's gray, but I honestly can't think of a better day to be inside. So I am thanking the Lord for rain because there's nothing better to do. So welcome to the Sanger SCAD Symposium. Just a few housekeeping items. It's okay to have your drinks in here. My boss told me that that's okay yesterday. So just don't spill is all. Wreck the microphones. And there are bathrooms both on the top floor, and there's bathrooms down here on the ground floor as well. And if you have trouble getting up and down these stairs, there are elevators that will take you up and down as well. Just let us know and we can help you. I hope you enjoy the swag bags. There will be more people here eventually, I think, as they trickle in, but we had over 80 people registered for the meeting, which really tells me that there is a significant need for us to put on events like this so that patients can meet one another. Let's do a quick poll. So if you're a patient or a loved one of a patient who has suffered SCAD, raise your hand if you've never met another SCAD patient before this weekend. Oh my gosh. That brings tears to my eyes. Okay. Well, I know. I cried yesterday and I'm crying today. That brings tears to my eyes. We put this conference on for you. And so you are right where you need to be. And I hope you find the day fulfilling, both from a mental perspective, but I hope you get a little bit of healing too as you meet one another and you encourage one another. So let us know. Let us know what you need to make the day successful. Just want to thank SCAD Alliance. We've got Catherine Leon, who's going to speak right after me, and you'll hear her story and about the organization, the board members of SCAD Alliance, all here who give their precious time to really help patients like you. I want to thank Sanger Heart and Vascular Institute for allowing us to use the space and for hosting this meeting. And I want to thank the Izzard family. It was their Izzard Family Fund, which has allowed us to put this meeting on today. So with these words of welcome, I welcome you, and I welcome Catherine Leon to welcome you as well.
Thank you, Esther, and welcome everybody. It's so great to see all your faces. And for the few people that I've met already and had to like run off, I'll catch up with you later. But I appreciated you coming up and saying hi because I want to get to see everybody and talk to everybody today. Like Esther said, we are here for you, and we're so grateful that you decided to come here to begin your SCAD journey if you're newly to this diagnosis. It is a very devastating diagnosis. It does affect the whole family, and you're going to learn so much today. I think you're going to be amazed at how you feel when you're back home next week. My story, now I'm going to cry. I don't usually cry about my story. My SCAD was in 2003, and it was related to pregnancy. It was about, though, 5 weeks after delivery that I actually had the heart attack. And that was 20 years ago. And so now I have 2 sons who are, yeah, I know. So I say that because I do want you to be encouraged that even though right now you probably can't even imagine what it would feel like to not think about SCAD every day when you wake up, but that will happen, and it might even happen in a year, it might happen in 6 months. So just give yourself time and be patient. Be patient with yourselves, and family members, be patient with yourselves too, because you're going through the same kind of adjustment. Along the way, I began to be curious why there hadn't been any research done. So around 2009, I started to reach out to some professionals and At that point, I'd educated myself about as much as I could on the internet, which was not saying much because there wasn't a lot of information. So we are so proud that we came together as an organization in 2013, and we have a board of 7, all volunteers, and we try to incorporate patients and caregivers. And we have had friends of SCAD survivors on the board before, because we always want to make it an integrated look at what the experience is like. We've been so fortunate for the medical leaders that we've met along the way. And key among those are Dr. Melissa Wood, who you'll meet after a bit. She was our first scientific advisor. And then, of course, Dr. Esther Kim, the dynamo. And then another advisor who couldn't make it because of flight delays. She's in California, but her name is Dr. Sahar Naderi. So today we are grateful to the board, also to the Izzard family, as Esther mentioned. And I don't want to talk anymore because I know you want to start learning. So thank you again for being here. And one note, since I spend my whole day running to the restroom, I'll just let you know that when you go out this way, you go to the right, and upstairs, you go out the door to the right. So if you need water during the day, if you need to take a break during the day, feel free to go in one of the lounge areas and just have a moment with yourself. Do that, because we don't want anybody being stressed or feeling ill from the day. All right. So welcome, and let's get learning.
I second Catherine. If the day gets overwhelming and you need some quiet space, there's tons of pretty quiet spaces that you can find. Feel free to wander. And if you get lost, we'll find you. And if you ask a question during the day, these microphones they work. So if you push the little button with the person on it and then you wait for the little red light to come on, then we can hear you. And we are recording today's sessions for those people who couldn't make it here in person so that they can watch it afterwards as a resource of SCAD Alliance. So please use your microphone so people can hear your valuable questions too. So with that, I'm going to introduce Kathy Izzard. She is an award-winning author and has kindly given all of us a copy of her book today. She's a philanthropist, has helped the homeless in Charlotte, and has also helped to develop mental health facilities in Charlotte. She is just an inspirational speaker and has been on the Today Show and even on NPR. But most importantly, she's just a wonderful human being and has a human story to share with you that I think will bring you to tears. And I'm probably going to step out so I don't cry again today. Thank you, Kathy.
Hey guys, welcome. Who was here yesterday? Is anyone in the room yesterday? I hope you did too. It was so amazing to have all that collective brain power working on this disease. We had researchers, cardiologists, the SCAD registry people, all coming together for this problem from different sides. It gave me so much hope about what might happen not only in 10 years, but what's going to happen just even in 5 years. So fair warning, there was a lot of technical and innovation yesterday. I will give you none of that. I am not a SCAD expert. I'm not about to deliver any kind of scientific or technical information, but I am here hopefully to give you some inspiration about SCAD, because SCAD affects the one heart that I love most in the world, and that is my husband, Charlie. We've been living with SCAD for 10 years. So again, like Catherine, a positive story for those of you who are fresh out. We are 10 years with it. And I ended up writing a book about it that you were all given this morning. They're free. And if there's any extras when we get out this morning, please take them back to your families and friends to help them understand what you're going through. It's called The Last Ordinary Hour, Living Life Now That Nothing Will Ever Be the Same. And I think that's what we're all trying to do now. We're trying to live life now that nothing will ever be the same after this diagnosis. Whether you or it was someone you love, we were all blindsided by this rare cardiac disease. And now everything has changed. Who knew that arteries could dissect? Who knew that someone who felt and looked really healthy could have a very complicated cardiac rare disease? For those of you who weren't here yesterday, I'm going to back up and tell you a little bit about what happened to Charlie and our family, and then share about how we're trying to live in this radical uncertainty. It all started in February 22nd, 2013. But to understand what happened to Charlie, you have to understand who he was before SCAD. This is Charlie about 25 years ago with 2 of our 4 daughters. You can see he was pretty strong and amazingly fit. He may have been the healthiest person that I knew. He ate well, he made fitness a priority, and he assumed that would guarantee he would never have a health crisis. He was an adrenaline junkie, and this is what he liked to do for fun. He heli-skied. He was fearless, and he would jump out of those helicopters and then fly down insanely steep mountains. Charlie worked in finance, but this is what he lived for, pushing his body to the limit, and he was in phenomenal shape. He wouldn't skip a day of exercise. Even if he was sick, he would go to the gym, which frankly was very, very annoying to me because I have to drag myself to a gym. There wasn't a single warning sign that anything was about to happen to us. We were out of town visiting our daughter, and Charlie very predictably went to the hotel gym. And I very predictably made up an excuse of all the emails I had to answer, so I would not go to the gym. So I was really surprised when Charlie came back after only about 20 minutes. And he walked in and he was holding his upper arms and he kind of shuffled past me and he fell on the bed and he said, "I'm so tired, I think I'm going to take a nap." And for my husband to take a nap was really out of the ordinary. So I got up and I went over and I looked at him. And I wasn't a doctor and I didn't know what could be wrong, but his hands were white, like ghostly white. And I thought, I don't know what that is, but I don't think it's good. So I got him up, I got him into the car, and as we got into the rental car, he kind of slumped against the window and he said, "I think you better hurry." And from there, it was just a wild ride. From the urgent care, we were there about 7 minutes before we were in the back of an ambulance and rushing to a hospital, and I had no idea where we were going or what was happening. We were met at the back doors by a surgeon who asked me who our doctor was in town, and I said, "We're not from here." And he said, "Okay, we don't have much time, we're going in." And they rushed Charlie away. Someone took me to an empty room, and I have no idea how long I was there. But finally, a nurse came and she said, "Your husband's had a heart attack." And I said, "What? When did he have a heart attack?" And she says, "You don't know that's why you're here?" I said, "I have no idea why we're here." And she said, "Well, your husband had a heart attack, but we think he's going to make it." So this is Charlie, that we thought he was going to make it. And they had put in 2 stents. His LAD had completely dissected. We found out that he had taken that nap that day. I'd be standing here with a very different story. Maybe each of you have similar stories. It's a miracle that you're sitting here. And at the same time, there are still so many questions. Is it going to happen again? Is there anything you can do? What is your prognosis? It's not like cancer where you say, "Okay, I'm going to get chemo and radiation and we're going to fight this." And you have that biggest question. Why? Why did it happen? Just like Charlie, I'm willing to bet you never saw it coming. So how do you live in radical uncertainty? How do you find healing when there is no cure? That's what Charlie and I had to figure out. That's why I spent 3 years writing this book, trying to answer some of those questions. But in case you don't have a time to read a book, or maybe you don't want to read it because it feels too close to your story, I thought I would give you takeaways that are what are woven into the stories of the book. These are the 4 most important ways that we found to live with the radical uncertainty of SCAD. The first takeaway, we cannot live in bubble wrap. As much as we wanted to just protect Charlie at all cost, it's impossible and an unsustainable way to live. We could not wrap Charlie in bubble wrap and hope we could protect him from dying. 10 years ago, the best doctors could tell us were things like, don't lift more than 20 pounds. Don't get your heart rate above 130. Stay very close to major medical centers. In fact, be kind of an hour away from a cath lab. So for a while, for years, we tried to follow all that. Charlie was beyond careful. He never ran or skied. He only walked. And we stayed very close to home. Even on vacation, we would check ahead to see where the cath labs were. We lived in bubble wrap. But honestly, it was pretty sad to see Charlie, that crazy heli-skier, living that way. It was kind of like a dog who loved to fetch and you'd taken his ball away. Charlie was alive, but there was no joy. So even though we were doing the things that were recommended to save his life, Charlie didn't feel like he was living. Charlie had to discover new passions and new joys that weren't things like heli-skiing or running. For Charlie, that meant discovering all kinds of things, like fly fishing. Charlie had never tried fishing. It was too slow, no adrenaline. Why try a sport where you don't sweat? But funny, my husband now tries to spend as much time as he can on a river. And guess what? After 10 years, we finally stopped asking and wondering if there's a cath lab anywhere nearby, which is part of my second takeaway. Get outside yourself and get outside. Charlie started to come alive on those rivers. It got us both outside. It got us outside ourselves and into the world. We started spending a lot less time on our to-do list and a lot more time on our bucket list. Part of that bucket list for us had always been to spend time in the West, specifically Wyoming. So we did. We started doing a lot of hiking in national parks and on wooded trails. We started noticing all the beauty around us. I started looking up and waking up to all the wonder in this world and not just worrying about heart attacks and dissecting arteries. Author L.L. Nost says, when life gets too big to handle, get outside. Everything looks smaller under the sky. I have found that to be true. Whether it's under those Wyoming skies or a Carolina blue sky, it reminds me how small my problems really are. And it made me start to ponder all kinds of bigger things, which is part of lesson 3. Medical emergencies cause spiritual emergencies. When our bodies are strong and life is going well, we don't need to ask about the meaning of life or even ask for help. Before SCAD, I think Charlie and I believed that we were strong enough and smart enough to handle just about anything that came at us. No outside help, no outside prayers required. Until this happened, I think about every problem I ever had I'd worked through with persistence and hard work. And I taught myself to be pretty self-reliant. But there's no amount of hard work or persistence that will solve or fix SCAD. Just like so many things in life, car accidents, brain tumors, the death of a parent, we all come to find out there are so many things we cannot control and we cannot solve. For me, that led to a huge spiritual search. Barbara Brown Taylor, one of my favorite authors, says, deep suffering makes theologians of us all. The questions people ask about God in Sunday school rarely compare with the ones we ask while in the hospital. Charlie's struggle with SCAD is something we cannot cure, so I must find a different kind of healing for myself. I have to find a way to live with the very uncomfortable knowing that someday we all are going to die. It's taken a lot of writing, a lot of thinking to deal with that. What this life is and what Charlie and I want the rest of ours to look like. Maybe SCAD has started that same search for you. Which takes me to my last lesson. What's worse than dying? For the longest time, that's the question that haunted me. What if Charlie dies? And I didn't think to ask the better question. What if Charlie lives? What is worse than dying? living as if you already are. Through some medical miracles, Charlie had been given second, third, even fourth chances to live. But with all the fear, we had lost perspective about what to do with those second, third, and fourth chances. We all know we're going to die. It's a given, but somehow we don't believe it's going to happen to us or to someone we love. But that's the truth. We will all lose someone we love. We will watch our friends and our family go through some terrible things. We will want to wrap our spouses and our children in bubble wrap and make sure nothing bad happens. But that's not the way this life works. I don't believe everything happens for a reason. There are terrible things that can never be explained and we can never comprehend. While I will never be grateful that Charlie has SCAD or all that has come with it over the last 10 years, I will always be grateful for the ways that it woke us up. Looking back, I think Charlie and I were sleepwalking through life, doing things that were expected, but not of our choosing. SCAD made us reevaluate everything, how we were spending our time, who we were spending it with, what we thought was important, what we did not want to leave undone. We started reconnecting to the wonder in this world and remembering how amazing it is to be alive. It does come with some risk. This is a fly fishing trip in Argentina that was part of our bucket list. And believe me, there is no cath lab anywhere near any of that. But we finally decided we had wasted too much of this precious life on fear. In closing, I want to read something from the last ordinary hour. There remains no cure for spontaneous coronary artery dissection, no life-saving pill or sure prognosis. There are hundreds of other diagnoses and many of life's most painful events that share this same truth. There's no way to fully recover from the death of a child or a spouse, whether from disease, accidents, or violence. After such a loss, we will not go back to who we were. Inevitably, when two hearts are bound by love, when one stops beating, others will break. For this, there will never be a cure. I cannot explain how Charlie, who actually has 2 rare diseases now and 3 near-fatal events, remains wholly alive today. Whether through the trinity of an exceptional medical team, the many prayers for healing, or his own incredible will to live. Whatever the combination, his unlikely survival remains a medical mystery to me. But I have come to understand there are no ordinary hours. Each breath is sacred, and every hour a gift. To all the doctors and all the SCAD registry people who took time from your practices and are dedicating careers to finding answers, thank you. To all you patients and your caregivers, spouses, people who love you, who came here today to learn more, including Lynn, who is just 5 weeks away from her SCAD and drove from Bristol, Tennessee, and Kevin and Linda, who I met this morning, who are fresh from a terrible SCAD on just January 31st. Thank you for your courage to be here today. To Catherine, Leon, and all the SCAD Alliance board members, Rachel, Maureen, Rebecca, Naisha, who for 10 years have been answering emails like mine from an ICU, volunteering all your time to give answers. Thank you. And to Dr. Esther Kim, for gathering us here and for being the amazing human that you are for such a time as this. May we all rediscover the wonder in our lives, recognize the holy in our everyday, and remember always, there's no such thing as an ordinary hour. Thank you.
Sorry, I forgot to pack tissues in your bags. Next time. Thank you, Kathy. That was so wonderful and just the right way to start the day. I hope already you have hope and you're surrounded by people with such resilience and grit in this room. So please lean on them for encouragement and for guidance. Woo! Okay. Sorry if I have mascara. um, so we're gonna dive right in and learn about our hearts, and we're gonna kind of start simple. And don't worry if you don't understand everything; it can be very overwhelming. And again, there are a lot of resources through SCAD Alliance, and these will be archived as well. Our first speaker is going to give a lecture on Arteries 101. How does my heart's plumbing work? Rebecca Young is a registered nurse, and she has a lot of degrees. She used to be a trauma ICU nurse, but currently is an outpatient clinic nurse at the esteemed FMD SCAD program under Dr. Heather Gornick in Cleveland, Ohio. And she has a master's in nursing through Chamberlain University, specializing in nurse education. We're so grateful that Rebecca could join us. She told me she's nervous because she's speaking to an audience this morning, but she teaches patients every day. And I told her just talk to you like she would talk to a patient in the clinic.
Good morning, everybody. My name is Becky, and affectionately, my patients call me Nurse Becky, which I love very much. So today I'm going to talk about arteries. I am nervous, so please bear with me. All right. This right here is my home in Cleveland, Ohio. I've been working at this hospital so long, it was only brick and mortar when I first started working there. Now we have this amazing steel going on. All right, and now we're going to talk about just really quickly the human heart. This shows the veins and the arteries, this diagram, just to give you a perspective of what we're actually thinking and looking at. I'm sure lots of you have seen the heart before, and this is kind of where all the blood goes around, okay? All right. Next, we have the cardiac cycle of blood flow. I was working closely with Dr. Gornick when I prepared this talk, and she thought it would be important to go over just what a normal EKG looks like. So here is your P wave going into your QRS, and up here it kind of talks about where the blood goes through the ventricles and the, I know what I'm saying, sorry. Anyways, yeah, so that's what normal blood flow looks like. Okay. Now, I put this little video on here to kind of show what it looks like. I'm not exactly sure how to make that play though. On the screen or just, oh, with the mouse. Okay, got it. Okay. Oh,
Actually, go to that.
oh, this one. Okay, thank you so much. Okay.
Veins are
Just
blood
watch
vessels
this little.
containing blood flowing to the heart, while arteries have blood flowing from the heart. The blue is representative of blood vessels containing deoxygenated blood, while the red blood vessels have oxygenated blood fresh from the lungs. Now, let's follow the path of the blood through the heart. The superior vena cava receives blood from the head, neck, upper limbs, and chest. Meanwhile, the inferior vena cava receives blood from the trunk, viscera, and lower limbs. Both the superior and inferior vena cava end up in the right atrium, one of the 4 chambers of the heart. The heart not only has 4 chambers, it also has 4 valves. The purpose of the valves is to keep blood moving in the right direction and not flow backwards. Blood exits the right atrium through the tricuspid valve, so called because it has 3 flaps, and enters the right ventricle. The blood exits the right ventricle through the pulmonary valve and enters the pulmonary artery. Again, it is an artery because blood is flowing away from the heart, but it is blue because it lacks oxygen. The pulmonary artery then splits into the left and right pulmonary arteries, which go to each respective lung. In the lungs, gas exchange occurs. The blood discards carbon dioxide and picks up oxygen. Now, blood comes back from the lungs through the pulmonary veins, entering the left atrium. Next, the blood is pumped into the left ventricle through the mitral or bicuspid valve. Finally, the oxygenated blood leaves the left ventricle through the aortic semilunar valve, entering the aortic arch. The aorta, which is the largest of all the arteries, distributes the oxygenated blood to the rest of the body. The aortic arch has 3 major branches, which supply the head and arms with blood. Then the aorta curls downward behind the heart, forming the descending aorta, which descends through the chest and continues down through the abdomen. In the abdomen, the descending aorta splits to supply the pelvis and legs with blood.
If you like this video, please like and subscribe. It would help me make more videos.
Okay, let me go back. All right, so the cool thing about this when I was thinking about the heart is that you don't think about how much blood is actually pumping through your entire body, but it's over 6,000 liters a day that is circulating all these arteries and veins, which is really interesting. And as the video told you, everything I have descripted there, I won't read that. So this right here is a normal EKG strip of someone who's in normal sinus rhythm. And this is kind of, what we go by when we're looking at things that don't look normal. All right. Next, we'll talk about the coronary arteries. So there's 2 main coronary arteries that arise from the aorta, the left main and the right coronary artery. A lot of you have probably heard of the left main. It's the most common site for a SCAD. And then we have off of there also is the left circumflex and the obtuse marginal branches. SCAD can involve one vessel, but it also sometimes involves multiple vessels, which I've talked to a couple of patients while I've been here, and more than one of you has had this occur in different areas of your heart. Oh, see my little, oh, there we go. Okay. So now we'll talk about an MI. A myocardial infarction is a heart attack. It's caused by a plumbing problem, not an electrical problem. So when I was showing you that EKG, that's your electrical system. The plumbing is the blood flowing through there. A blockage in the coronary artery leads to impaired blood flow and causes death to the heart muscle, which is called an infarction. An artery tear, as you can see on the bottom picture here, is one cause of MI. Although plaque from atherosclerosis as well as a clot can also cause myocardial infarction. So it's diagnosed based on symptoms. So people will complain of chest pain, radiating to the arm. Women usually have different symptoms. A lot of times they'll complain of right scapular pain. That seems to be a pretty often occurrence with women. Then you'll have an EKG done, blood test to check the troponin to see if there's damage to the heart muscle. All right, now on this one, this is an EKG of a SCAD in the LAD. So you can see that you have ST elevation on the strip itself. And here is a picture of what that looks like on the actual cardiac cath. So this picture right here is what it looks like from the electrical site. And then these are our actual patients too that we care for in Ohio. And this one is, we were talking about the OM branches of the left circumflex. This is a non-ST elevated heart attack. And as you can see where the arrows are pointing, that is what that looks like in those arteries. And here we have a SCAD of the branches of the right coronary artery. And the arrows also are pointing to those areas. And these are all from cardiac caths. And right here, you'll hear that word a lot, tortuous arteries. A lot of times, even if patients don't have FMD, they can still have these tortuous arteries seen on their cardiac cath and also on other imaging like CTA. So next here we have the connection between FMD, SCAD, and carotid artery dissections. So there are a lot of people that fall into the category of FMD-like because they do not have the classic string of beads. That does not mean that we treat you any differently. We're still going to medically manage you the same way that we would if you were actually diagnosed with fibromuscular dysplasia. And the same with a cervical artery dissection. Sometimes they just happen and it's from the tortuous arteries or, you know, some other underlying connective tissue disorder. So the important next step in this is to get head to pelvis imaging. We need to check all of the vessels in your body to make sure that you don't have fibromuscular dysplasia, because that leads to aneurysms and things like that in other arteries of your body. There's my little nurse. I love her. Okay, now this is our case study. This is one of our patients, 46-year-old woman with non-ST elevated MI. She had a SCAD of her OM branch of her left circumflex. After that was discovered, we did our head to pelvis CTA. We have a scanner at our main campus in Cleveland that can do the whole body in one scan. It's one dye and one radiation exposure. It's very nice. And it's pretty quick for the patients. It's pretty seamless. So they tell us how quickly and painlessly it was. So we're happy about that. After getting her head to pelvis imaging, we found that she actually does have FMD of her renal arteries, her external iliac arteries, as well as her internal carotid artery. Here, these are her, some of her imaging here that shows the beads. And next we have her iliacs. And you can see that she's got beads as well as some tortuous. And Dr. Gornick said that this would be good pictures for you guys. Oh, okay, sorry, yes. Okay, so right here is some beading. And then this over here. And then in the iliac, you can see all of this. See how there's like multiple beads? It looks just like the sugar beads. And this will present as leg pain, difficulty walking, things like that. Patients do have different kind of symptoms, but most of the time it's leg discomfort. All right, and this is my team in Cleveland, Ohio. On the left is Melinda. She is our dedicated FMD sonographer. There's me, and there's Dr. Heather Gornick, who is one of my favorite people on this planet. Our research coordinator, Dina, she does our SCAD and FMD registry at our hospital there, and then our administrative assistant, Stephanie. And I just want to thank you for your time and thank you for being patient with me during this. And I became a nurse because your life is worth my time. And I thoroughly enjoyed caring for FMD and SCAD patients. It has really made a huge difference in my life, being able to support all of you during your times of anxiety and stress and the unknown that's coming. So I just really am glad that I can be a part of all of this. Thank you.
So we have Dr. Agnes Casso, who is a T32 postdoctoral research scholar and clinical instructor of medicine at the University of Pittsburgh Medical Center. She is a local site principal investigator for the SCAD registry, and her clinical and research focus is on cardiac problems in pregnancy. And today, so Agnes, Rebecca went through Arteries 101, and Agnes will be going through Cardiology 101. So all the tests that all the doctors order for you, you'll maybe get an understanding of why we're ordering those studies. Thank you so much.
Hi, good morning. It's my honor to be here. Thank you so much for having me. And just as Esther had alluded to, I'm going to talk to you a little bit today about some of the tests and procedures, and really actually backing up and talking about the journey that some of you may have taken in really just being diagnosed with a heart attack. I tried to structure this PowerPoint almost in sort of a time-wise fashion, first focusing on actually getting your diagnosis, and then going through potentially tests looking directly for SCAD, and then which procedures that you might go through if they're going to go about fixing the blood vessel for SCAD, recognizing that everybody's journey is really different. And so if you went through this in a different order, that's, totally, we see that all the time with this condition. So let's start with diagnosing a heart attack. So I wanted to start with a terminology slide because I'm sure you guys know that we use a lot of medical jargon in the health system. So I'm sure with all of your medical notes, and I'm sure even doctors talking to you have used kind of phrases or acronyms. And I just wanted to kind of go through some of the probably common ones that you hear and you've experienced and kind of talk about those a little bit. So the first one, and I'm sure you guys have seen many of these, is your ECG or your EKG, one of the probably first things that you had done as far as tests when you came in with your symptoms. EKG or ECG stands for electrocardiogram, and we'll have pictures of that in the next slide. MI, if you've ever had a doctor say, when was your MI? Of course, you should know what that means, right? It stands for myocardial infarction, and really that's just a fancy way of saying heart attack. So if you hear or see on notes MI, or a doctor asks about your MI, really they're asking about, the incident with your heart attack. When you see written or a doctor asks about STEMI or NSTEMI, STEMI is an acronym for ST elevation, which is an EKG finding. I'll show you an example of that. And then the MI is myocardial infarction, heart attack. And non-ST elevation MI is a non-ST elevation, which refers to, again, to an EKG finding, kind of a pattern that we see on there, and then MI, heart attack. So to make a heart attack or an MI diagnosis, typically a cardiologist or a doctor or healthcare professional will look for the combination really of chest pain, EKG kind of patterns, and cardiac enzymes, which are things that we find in the blood, and most often you guys will hear about troponins, which are sort of these sensitive enzymes released by your heart when essentially your heart's in distress. So these are some examples. I'm sure you've probably seen your own ECGs or EKGs at some point. And when we talk about these ST elevations, we're sort of referring to one of the patterns that we see on the EKG. So on the left-hand side is quote, quote, a normal EKG. And I'm just sort of highlighting with the arrows the segment of what we look at when we say an ST elevation. So it's sort of a technical term to us. It may mean, the day we presented with our major heart attack. And when doctors or healthcare professionals say STEMI, they're referring to the elevation of one of the segments on the EKG. And really what an EKG is just a drawing of the electricity of the heart. And when the heart muscle gets damaged during a heart attack, the electricity changes because the electricity has to kind of bypass that damaged part of the heart. And so that creates distinct patterns that help us diagnose a heart attack. And similarly, normal on the left side, on the right side would be a non-ST elevation MI, where we don't see the elevation of that ST segment. Instead, we either see a flattening or a depression. So these were probably patterns that when you presented with your condition, a doctor, healthcare professional took a look at your EKG and first started to realize, there's something really coming from your heart, linking it to your symptoms. So I'm sure one of the things many of you guys have also had is called an echocardiogram. We often use the sort of nickname or shortened term echo when talking about it. It's really an ultrasound for your heart muscle. It also can assess your heart function, how well we say your heart is pumping, and we can also take a look at your valves. It involves essentially just some gel and ultrasound probe that will probably, as you guys know, be at separate parts of your chest and kind of looks at your heart from different angles to kind of look at it really comprehensively. It's really nice because it doesn't involve any radiation or any contrast dyes, so it's really safe and usually should be a really painless procedure. Some of you may have had an echocardiogram or an echo even before you had your SCAD diagnosis, when you came in and you had your symptoms, and maybe your doctors were needed a little more information to see what is the heart muscle doing? Is it in distress? Is it not acting right? And then most of you probably got an echo or an echocardiogram after your SCAD diagnosis to see, was there damage to the heart muscle after your heart attack? And some of you may have had multiple echoes or echocardiograms to kind of follow, did the heart muscle get better? Did it heal over time? And this is just a picture from one of my lovely patients and an example, sorry, it keeps jumping like that, of an echo. And it's this really, I always think the heart muscle is really beautiful. A picture of the heart in what we call a 4-chamber view. We take a look at it. Sorry, I don't know why it's jumping like that. Oh, yeah, probably, huh? And it is sort of this really beautiful moving video. And interestingly, the heart is, it's upside down and backwards. And so when we talk about the left ventricle, if you guys have heard that, or we talk about it as sort of the workhorse of the heart, that's on the top right-hand side. And we're kind of looking to see how well is that workhorse of the heart kind of pumping. And that's really the chamber that can primarily get damaged during a heart attack. So sometimes we'll report what's called an ejection fraction. And that's basically just a measure of how well the heart is pumping. When we talk about sort of normal ejection fractions, we usually refer to that between 55 and 60%. That can be lower when you present with your heart attack, just because your heart's kind of in distress in the moment. Luckily, with many patients, over time, we can see that get better and heal. Back to my clicker. Okay, so moving on, so we've made the diagnosis now of heart attack. So now we're going to look directly for diagnosing SCAD. So oftentimes, there's major concern for a heart attack. You will be taken to what's called a cardiac catheterization lab. And this is where we'll get a really sort of direct visualization of the blood vessels. So you'll be taken into sort of what's called a cardiology suite. It's sort of like a semi-sterile room. And you'll sit on this not incredibly comfortable platform, but there'll be a doctor kind of sitting to your or standing to your right, and then you'll have a screen sort of on the left-hand side. If you guys remember this, I'm sure there's so much going on during that day. But essentially, there's what's called fluoroscopy, which is essentially continuous X-ray, and it takes pictures of your heart from different angles. And if you'll remember, it kind of rotates above your head, and it'll take pictures from different angles of the blood vessels of your heart. And this is really the primary way that we diagnose SCAD. And what the pictures that we take in the cardiac catheterization lab are called coronary angiograms, or caths, as we sometimes abbreviate it in medical jargon. And essentially what happens in the cardiac catheterization lab is we will place a catheter, which is essentially a small thin lumen, into either a blood vessel in your wrist or your groin. And then we'll snake up with the catheter to your aorta, which is the big blood vessel before the heart where the coronary arteries will take off. And then your doctor will shoot contrast dye into this catheter. And this will be the way that your blood vessels will be illuminated. And then we can take pictures on continuous X-ray. And this is a modality by which we can really only see the lumen or the inside of the blood vessel. And as you guys know, SCAD is sort of an outside of the blood vessel phenomenon. So we can kind of look for patterns that are diagnostic for SCAD. And this is just kind of a picture. Again, it's like kind of a movie, a continuous X-ray. And this is kind of what it looks like. So again, just the limitation really of cath or our coronary angiograms is we really can only see inside the blood vessel, and SCAD is this condition really where things are happening outside of the blood vessel. So sometimes you may have heard that the doctor was kind of uncertain about whether or not you had SCAD, and you may have been sent for a CT scan or an MRI scan. And this is kind of what the scanners may have looked like. So again, you sit on this not so comfortable platform, and you go into sort of this circular donut tube, and there's pictures taken of your heart. And these are kind of what the pictures may look like. This is an example of a CT scan, and the blood vessel sort of coming down on the picture. The nice things about these imaging modalities is with a coronary CT scan, we can actually see outside of the lumen of the blood vessel and see if there's that blood hematoma, which is a really unique feature that we really can't see on cath. And then on cardiac MRI, we can see if there's any scar damage from the heart attack. And we can also assess, kind of like what we do on echo, the ejection fraction, or how well the heart is pumping. Okay, so now we've diagnosed SCAD, we know what's going on. So perhaps we're going to move on to fixing the vessel. So as far as treatments, luckily, most of us, it's incredible, our body can actually heal the vessel itself, right? So for a lot of us, not much was done maybe in the cath lab. We just kind of, with medications, and allowed our body to sort of naturally heal. Sometimes though, we make a medical decision to put stents in. So what are stents? Or first of all, why do we put stents in? So sometimes we'll put in stents for these types of scenarios. So if we see that the SCAD is occurring at the top of the blood, the coronary artery, such that the coronary artery is supplying a lot of the heart muscle, and we're really worried that there's going to be a lot of damage done if that heart muscle doesn't get oxygen for a long time. If the patient is having chest pain and you know, it's not going away, and you're on the cath lab table and we're kind of worried, you know, there's heart damage going on. If your blood pressure is really low and we're worried you're going into shock, or if you're having really bad electrical rhythms, oftentimes we make the decision to really just try and open up that vessel right now. We need to get blood to that heart muscle. So what happens when we stent? So essentially, the doctor will thread onto the catheter a balloon, which has a stent on top of it, and it will sort of position it in the narrowest part of where the hematoma or your SCAD is. And then they'll actually inflate the balloon, sort of using, you know, equipment outside of the body, and the stent will actually expand and push the hematoma away from inside of the lumen. And then once the balloon is fully expanded, the balloon will sort of deflate, and they can remove the balloon, and then the stent will be left there. And really the purpose is for it to sort of push the hematoma away from the lumen so that blood can now return to your heart muscle. And then sort of more rarely, we will also turn to surgery. And what a procedure that's called coronary artery bypass grafts, or CABG, is you may have heard some people refer to it. And that's when we take arteries or veins from elsewhere in the body and we actually bypass the area of the SCAD segment. So sometimes we'll hook up the artery to the aorta that's receiving the normal flow, will bypass the disease segment, and then the blood will be able to return to the heart muscle that's sort of beyond the damaged area. And that's sort of all I've got. I'm happy to take questions. This is our Pittsburgh SCAD clinic. We are all really passionate about the care of this condition. So yeah, and thank you so much for having us. Oh, okay.
Thank you so much. I hope everyone has a better understanding of your heart and the tests that were done. We're going to now move out of the heart and talk about the vasculature a little bit. I'm really happy to introduce Dr. Daniela Kadian-Dodoff. seems like a long time ago, but I might have helped to train Dr. Katie and She did an external rotation at Cleveland Clinic when I was an attending there. And I knew she was going to be a star, and she is. She is now one of the world's experts in fibromuscular dysplasia. And she is an excellent diagnostician and speaker, and she is assistant professor of medicine at Mount Sinai Hospital in New York. And you're really in for a treat hearing from one of the world's experts. Thank you, Daniela.
Thank you so much. It's really an honor to be here with you all today. And thank you to Esther and Catherine and the Planning Committee for having me here with you all. So I'm going to talk about fibromuscular dysplasia and other artery abnormalities. These are my disclosures. None are really relevant to today's talk. And my hope is that after the talk today, that you'll recognize that SCAD is a manifestation of an underlying artery problem, or arteriopathy is the medical term we're going to use for that. And I'll start with just an overview of the anatomy of a dissection. You've probably seen this image or something like it before. This is a lovely figure by Dr. Kim. So I think of the arteries as pipes, and they should be straight and smooth and providing blood flow to whatever's being supplied by that artery. And the artery wall has 3 layers to keep it nice and strong to withstand the body's blood pressure. And what happens with dissection is you get a disruption in the layers of the artery wall. So if you look at the bottom left, there's a tear into the layers and a lifting of one of those layers, blocking blood flow. Alternatively, you can get a separation and formation of a blood clot that kind of blocks the blood flow to whatever's being supplied by that artery. And if that blood clot grows enough, you can even completely block off the artery itself. So these are different types of appearances with dissection, and this is why we're all here today. So this is a patient of mine who had crushing chest pain at 45 and had a SCAD. So you can see here that her blood vessel suddenly goes from looking pretty nice and open to very narrowed and then back to a normal size. And so as you heard, when we do an angiogram, you can only see the blood vessel from inside the artery, so we can't see the blood clot that's actually causing that narrowing to happen, but this was a SCAD event for her. So she also complained of hearing a whooshing sound in her ears, and on ultrasound, which is shown here, you can see that her blood vessel actually has a loop in it, and then on the other side, instead of being nice and smooth, she's got what looks like kind of bumps on the artery wall there. So she ended up having fibromuscular dysplasia. So when we think about SCAD overall, it accounts for about 35% of heart attacks, particularly in women under the age of 50. It's the most common cause of pregnancy-associated heart attack, but actually women presenting or pregnancy-associated SCAD is a small percentage of SCAD overall. And about 50% or so have some kind of a factor that they can recall around the time of the event, whether it's exercise that's very intense or Valsalva, vomiting, heavy lifting, intense emotional stress. We look for recreational drug use in some of our patients when we're can't find anything, and then exogenous hormones as well. Yeah, and so how do we know that SCAD is a manifestation of arteriopathy? Well, we have some data available to us. First off, multifocal FMD, which is the string of beads, is the most common thing we find when we look outside of the heart. We also find a much higher rate of cerebral aneurysm than the general population when we look in SCAD patients. And then curvy arteries, making lots of twists and turns, is common in the coronary, and then arteries outside of the heart in patients that have SCAD, which supports it's not just something's not just happening in the heart, it may be all the arteries that are affected. And so based on this data, the recommendations from the guidelines are that any patient presenting with SCAD should have a head to pelvis CTA, preferably over MRA, to screen for what their arteries look like. And that way we know what we need to keep an eye on and how to counsel our patients. So these are the things we're looking for. And I have here a spectrum. So to the far left are findings that may not mean anything. You may find these in patients that have never had a dissection, like the curvy arteries or a different branching pattern of the aorta going to the head and the neck. And as you move to the right, it becomes more indicative that there is an underlying artery problem, whether there's an aneurysm or a dissection, or the most specific multifocal or focal FMD, that beaded artery in the top right that you can see here going to the kidney. So it's not nice and smooth, it's got bumps on it. And there really isn't another pathology that causes this string of beads or this focal area of stenosis, which we see in some patients with focal FMD. So when we see either of these two appearances on the artery, we can give the patient the diagnosis of fibromuscular dysplasia, because that's the only thing that causes this appearance in the arteries. The last three, dissection, aneurysm, and tortuosity, can be caused by different things. And so we can't tell a patient they have FMD unless we see the string of beads or focal narrowing. Okay? Does that make sense? Okay. So what is FMD? Well, it's not related to cholesterol plaque, meaning it's not atherosclerotic. It's not an inflammatory process in the body. It most often affects the carotid arteries in the neck and the kidney arteries. And we can see any of these manifestations in a patient of FMD. But again, we can only say the patient has FMD if they have one of the two appearances at the beginning, the multifocal string of beads or the focal stenosis. So this is data from the FMD registry. And when the registry had over 900 patients, we took a look to see how common was aneurysm and dissection in this group. And it's actually very common. So up to 42% of patients will have an aneurysm and or dissection when they're imaged. And the most common locations of aneurysm or dissection in FMD mirrors where we typically see FMD, in the carotid and the renal arteries. So a lower percentage of patients within this cohort had coronary artery dissection. So it's not the most common site of dissection for patients with FMD. And what is becoming more apparent is that there is a spectrum in how patients with FMD present. So this is that 45-year-old patient that I started with who had the SCAD event and was found to have carotid multifocal FMD. Her sister had hypertension and a carotid bruit on exam. And so we screened her, and we were able to see that she had carotid FMD. So you can see the bumpiness in the arteries on this B mode or gray image here. And then on color, that the blood flow is not all the same color. It's kind of swirling in there. We use that color to indicate the direction of flow. So oh, thank you. A bruit. A bruit is a whooshing that we can hear with a stethoscope. So you may hear whooshing in your ear if you have pulsatile tinnitus, as the blood flow is going past an area of string of beads, for example. And if we take our stethoscope and put it over that area, we can sometimes hear it. And so we will look for that when we're evaluating patients in clinic. So she ended up having multifocal FMD of the renal arteries and the carotid arteries. Now, there was a third sister who was younger, 39, with no symptoms. But because the two sisters had findings, we asked her to come in and get screened, and we ended up finding that she had only splenic artery aneurysms. So had I met number 3 first, I would not have been able to tell her she has FMD because we don't see string of beads. But because of the family history, I think her manifestation of aneurysms is probably on that spectrum of FMD. So there may be some of you who have undergone imaging and you don't have FMD, but you have other findings. And so this is what I'm getting at. And what I term patients like that is FMD-like or arteriopathy NOS, which means when we look at you on paper, you fit kind of the profile of what an FMD patient would be. You're in the prime of your life, you're otherwise healthy. Typically, you don't have a lot of cardiovascular risk factors, and this event kind of hit you out of nowhere. And truthfully, it doesn't matter if I can give the FMD diagnosis to a patient in terms of how I manage them. It doesn't affect the guidance that I give or the medications that we give. But sometimes people, I can't give you a name either for why what you have yet. We don't know how to define this yet, basically, is what I'm getting at. So what we're looking at with FMD-like is that there's arterial dissection, aneurysm, or tortuosity without the string of beads or focal stenosis. Some patients are sent for genetic testing, and that's negative in this scenario. And it's a diagnosis of exclusion. So we have no other explanation for why this happened, but something is not right with the arteries, basically. So when you go for genetic testing, we're looking for what are called the syndromic arteriopathies. So these are conditions in which we've identified a gene, we know what the mutation is, and we're trying to make that diagnosis with our genetic testing. So this on the far left is Ehlers-Danlos type 4 vascular type. It's due to a mutation in the COL3A1 collagen gene, or sometimes COL1A1. And patients with this condition can present with dissection, aneurysm, arterial rupture, or intestinal or uterine rupture. And there's some classic facial findings that have been described in some of these patients, although not everybody that has vascular Ehlers-Danlos will present with this. So kind of deep set eyes, a thin upper lip, very frequently a thin nose bridge, sometimes premature aging of the hands too, from a lack of subcutaneous tissue can be seen, or fatty tissue in the hands. And then Loeys-Dietz syndrome, which is a mutation in these genes, and this manifests classically with a lot of arterial tortuosity. So the arteries kind of turn back over on themselves and even have loop-de-loops. You can see in the head and neck here. We'll often look in the mouth to see if the uvula is normal when we see patients in the office. And then wide-spaced eyes and a small mouth are the other features that we can sometimes detect on physical exam. And then Marfan syndrome is a mutation in the fibrillin-1 gene. Here's some famous people who had Marfan syndrome. You may recognize this guy from Ghost. And then the actor who played Chewbacca also had Marfan's. But typically the wingspan or the arms are very large. So there are, again, some features we can look for, and I have some pictures coming up of what that looks like. Most of these are autosomal dominant, which means you only need one copy of the gene for it to cause a problem. And their family history is very important when we're evaluating patients to help us determine whether or not we need to send patients for genetic testing. And it's a part of the diagnostic criteria often for us. Other things that patients with Marfan's can have is a dislocated lens. So that's just an image of that. And then when you get that echocardiogram, it will look at the aortic root or the start of the aorta. And there are some guidelines about what a normal size is based on your gender and how, what your body type is, how big it is. And we use that, what's called a Z-score, to determine if your aortic size is normal for you or not. Here's some other signs of connective tissue disease that we're looking for on exam. So a pectus deformity, which is when the chest wall kind of goes in or out. We may have you do some kind of exercise in the room where we try to encircle your wrist or see how flexible you are in the small joints or able to touch the ground without bending your knees. And that helps us define how hypermobile you are. And it may help us decide whether or not genetic testing is going to be useful or high yield, meaning we think something will actually come back and give us an answer. So what do we do with those vascular findings that we find, and how do we manage them? Well, we don't have any specific guidance for aneurysm and dissection specific to SCAD or FMD. But if we do find a genetic diagnosis like vascular Ehlers-Danlos or Loeys-Dietz, it may help us to change the size criteria for how we would manage a patient. But we use general guidelines, basically. We don't do any specific SCAD or FMD guidelines, or we don't have any. For incidental dissections, meaning we found a dissection, but the person never knew they had it, typically just a baby aspirin a day is all that's recommended. If we find somebody who has a dissection outside of the heart and they have symptoms, that becomes a discussion about either more antiplatelet therapy, like Plavix, for example, or a full dose aspirin, or even full dose anticoagulation. And that's a very patient-specific decision based on the location and symptoms and risk of bleeding. But what becomes very important is coming up with a plan for surveillance when we find aneurysm or dissection. So when are you going to come back? When are we going to look at this again and make sure it's not changing? So essentially, when you have an aneurysm or dissection, it is a sign of an underlying arteriopathy and more work needs to be done. You need to have further imaging and further discussion with your doctors about any findings that are outside of the heart. And getting that imaging allows us to identify patients that might need more evaluation with a genetics team, for example, if we're seeing aneurysms and dissections in other locations, but there's no beating of FMD to account for it. It may help us find lesions that we need to monitor. It may help us inform or at least get the right people involved in terms of family planning and also family screening if we need to look elsewhere. And it may allow us potentially to better prognosticate patients who have isolated findings versus findings in other places in the body. But this is an area of active research. So we absolutely should be screening more patients. And I want to just talk a little bit about what I say for family members, because that's always a very big question that people have. Since we know that SCAD is partly genetic, what about my family members? So this is what I say. I tell the patient if their family member can come in, I'm happy to see them. But if not, they need to at least tell their family members, first degree, siblings, parents, children, to ask their doctor to listen to the neck up by the angle of the jaw, because that's where FMD happens, not down here where a lot of people have been trained to listen, for that whooshing sound, the bruit, and also the belly. And if they hear something, we need to further evaluate them. If they have early onset high blood pressure, age 40 or younger, they need to be screened. If they have blood pressure that's hard to control, they should be screened. If they have severe migraine headaches, or if the person can hear a whooshing sound, they need to be screened. Definitely if they've had a dissection, if they have tortuosity on imaging or aneurysms in other locations, they should be screened. But it's important to know that the mean age of diagnosis for FMD, as with SCAD probably, is around 54 years. So if we image someone in their 20s and we don't see FMD, we don't really know what happens up to the age of diagnosis. So I can't say for certain that things will not change with the arteries by age 54. Okay. So if they develop any of those list of symptoms that I went through since I've seen them, or they're thinking about having a family, we should screen them again. Okay. And with that, I thank you very much for your attention.
I just wanted to start by saying, I'm so excited to be here. My name is Hannah Chaudhry. I'm an interventional cardiologist. I currently work at Dartmouth Hitchcock Medical Center in New Hampshire. I went to medical school in the South in Louisiana, and then I did my training in internal medicine at Dartmouth, and I did cardiology and interventional cardiology. And for those of you who don't know what interventional means, I basically am responsible for doing the procedure, which oftentimes diagnoses SCAD, and then putting in stents and doing some other additional interventional procedures. And I did that training at Brown University, and I'm currently a staff interventional cardiologist at Dartmouth. So it was really interesting to hear all of you asking questions about what SCAD actually is. I think it's a little bit difficult to actually understand. We all know that SCAD, or spontaneous coronary artery dissection, is a tear or a rip in the arteries that supply the heart, but sometimes it's hard to conceptualize what that exactly means. So I'm going to try to do a little bit of anatomy lesson teaching of what our heart arteries look like and what SCAD actually looks like when we take pictures in the cath lab, and kind of how we first see the disease present. So just to kind of start off first, this is what our heart arteries look like. The coronary arteries have 3 layers. There's the intima, which is the innermost layer, the media, which is kind of this middle layer, and the adventitia. So each layer serves its own purpose. The innermost layer is kind of, it's thin, it's smooth, it's the barrier between the true lumen or the inner lumen of the artery, which holds the blood that travels throughout our heart. The middle layer is kind of what gives arteries their strength. It has more of the smooth muscle in it. And the outermost layer is the adventitia, or kind of the flexible, kind of stronger layer that holds the artery together. So when we're talking about SCAD, I know there was a really good question about, is SCAD, it's a dissection, is it a tear, is the blood spilling out of my artery? And I think I'm glad that you said that, because I think that's what most people think when they hear dissection. It's not truly that, though. What happens is there's blood that collects between the layers of the arteries, and that can manifest in multiple different ways. So initially, when SCAD first came out, we thought that it was what you see over here in C. So there's a tear in the intimal layer, the innermost layer kind of tears or rips. And when that happens, blood can then seep into the media, or the middle layer, the smooth muscle layer. And some of it can be free flowing in and out into the true lumen, but oftentimes we've realized that it's not always a tear. Sometimes it can just be within the media, which is the muscle layer. So there's a tear or a rip within that layer that then starts to bleed. It kind of becomes a little bruise, and anytime something bruises, it increases in size, right? The blood kind of pools and collects. And so if you can imagine what your artery looks like, if you start to create a space in between some of those layers, that space is going to start to encroach on the true lumen, or the lumen where the blood is supposed to be, where the blood is supposed to bring blood to other parts of the heart to supply the heart. And this is what we see more often than not. And I'll go into kind of what the types of SCAD looks like for us and how we diagnose it. But basically, that when that hematoma or blood collection expands, it encroaches on the true lumen, and we start to see an area of stenosis. So it's a different mechanism than true atherosclerosis or cholesterol buildup, but it can mimic that and it can look the same. And that's why it's sometimes challenging for us to determine what we're dealing with. So I hope that helps to kind of clarify what the dissection means and where it's actually happening and what the tear is. So when we talk about spontaneous coronary artery dissection, in terms of a definition, it occurs in an epicardial artery. That's a main branch artery. We know that the heart has those main branches that we can see on our cath. And then the heart also has very little tiny small arteries that we don't often see. And that's important, because what we are describing as SCAD or dissection happens in these larger arteries. It's not associated with atherosclerosis or cholesterol buildup, which is the number one cause of having blockages or heart attacks. We're talking about a rarer entity that's not related to atherosclerosis or cholesterol buildup. It's not related to trauma either. And it's not iatrogenic. We talked a little bit about iatrogenic dissections, meaning dissections that happen when we are instrumenting the arteries or when we are doing procedures. So it's not related to that, and it's not in the setting of a complication. It's spontaneous, meaning it just happens. So how does SCAD present? You all know this probably better than we do. The symptoms are variable. Most commonly, however, people present with chest pain. So about 95% of the time it presents with chest pain. Oftentimes, or half of the time, it radiates to the arm or the neck. But people can come in with atypical symptoms, just like patients can present with atypical symptoms in the setting of coronary artery disease. SCAD can present differently as well. It's most common in younger women, we know that, but it can also happen in men. It can also happen in older women. Many present with acute heart attacks. We talked a little bit about what things can look like, what the EKG, the electrocardiogram, can look like, and the troponin elevation. So oftentimes when people present with SCAD, when we see them come to the emergency room, they look like they're having a heart attack. 7% of people can actually present with bad arrhythmias, including ventricular tachycardias and ventricular fibrillation. So what do we do next? Usually when someone presents with a heart attack, the first thing that we think about is the cath lab, if you're close to a cath lab. And most often, because SCAD presents in this typical kind of heart attack-like fashion, people do get a heart cath procedure done first and foremost. So what is a heart cath? So this is something that I specialize in. This picture depicts us going up from the groin, but as you may know, we're no longer predominantly using the groin as our access point. We go through the wrist these days. So a catheter is inserted into the leg or into the arm, and it's small. It's like a straw. It goes all the way up through the aorta into the coronary arteries. And what we do is we inject the arteries with some dye, and this dye shows up on the X-ray. So we'll talk a little bit about what the X-ray images look like and what's actually happening in your arteries if you look at them in kind of a cross-sectional analysis. So this is kind of what we see when we see SCAD. So in the first image A there, I think you can probably appreciate the darkness of the artery, which is what it should normally look like. And there's a linear density, like a white line inside the artery there. That white line is depicting a dissection flap. So that suggests to us that there is a dissection, meaning there's an actual tear. So this is not where we're just bleeding into the artery wall, but there's an actual tear in the artery wall. And we can sometimes see this kind of image where we see a suggestion of a dissection flap. Now, that's not always present. If we see that, it's great because that is kind of pathognomonic or really suggestive of a dissection. And what you can also see is the other arteries, they look really smooth. There's no bumps, there's no blockages in them. And that helps us also diagnose SCAD because SCAD, as we know, is not related to atherosclerosis. It's not related to heart cholesterol buildup. SCAD doesn't always look like this on the angiogram. As I mentioned, sometimes there are instances where you have bleeding into the vessel wall, but there's no actual rip or tear. And that is a little bit trickier for us because it can look like just a stenosis. It can look like a blockage or a narrowing, which we're used to seeing in relation to a cholesterol buildup. One of the keys that we look at, though, is the other arteries. How much cholesterol is in the other arteries? If there's a lot of cholesterol in other areas, most likely this narrowing that we are looking at is probably related to cholesterol buildup. If there's no other narrowings, that's more suggestive to us that, hey, maybe this is something else. Maybe this is bleeding into the vessel that's encroaching on that lumen. Picture D, and we'll talk a little bit about this. So as you can see, sometimes there's subtleties in terms of how we diagnose SCAD on the angiogram or on the cath. If it mimics cholesterol buildup or if it mimics a stenosis, sometimes it can be really difficult for us to pinpoint exactly whether it's a dissection or not. And oftentimes we can use imaging being little cameras, and some of you may understand what I'm talking about if you had it done. We can take small cameras into the artery, and when you take that camera into the artery, you can see exactly what the artery looks like, and you can identify things like hematoma or bleeding into the heart vessel, or that dissection flap that we talked about. And picture D is a depiction of what we call OCT. It's called optical computer tomography, and it kind of re-renders what the artery is supposed to look like for us. These are some other pictures to kind of help you understand what's actually happening in the artery, because if you can see on the angiograms, on the pictures that we take in the cath lab, it's really difficult to tell exactly what's happening in the artery because you're not looking at it through a microscope. You're not looking at it inside. You're looking at what it looks like on the outside. So in picture one, again, you can see that kind of white line, and that white line, as I mentioned, is that flap, that dissection that's been created by the SCAD. And if you look up top, you can see that's that's a depiction of kind of what the artery should look like and what it would look like to us on the angiogram. Picture 2, again, is the same concept of that bleeding into the heart muscle, into the muscle layer of the artery. And that, again, is a little bit trickier sometimes for us to distinguish between a blockage versus just bleeding into the heart vessel. And picture 3, again, if you hadn't been looking for or thinking about SCAD, you could misdiagnose that as just a blockage. So there are some subtleties in what things look like. So as I mentioned, oftentimes when there's some question about whether or not this is a dissection versus a blockage issue, we can use these cameras that go into the artery to help us identify better what we're looking at. Intravascular ultrasound, again, it's a small probe that goes inside the coronary artery to help us determine what we're looking at. So if we go back to picture 1 and we look up at the first column here, you can see, if you look at the angiogram, there just looks like some areas that aren't quite right, but we don't see a dissection flap. We don't see a true dissection. It may be blockage related to coronary artery disease. It may be SCAD. But if we take the ultrasound into the artery, you can see the lumen of the artery. If I can point this out to you. So TL, which depicts the true lumen, and this kind of false lumen. The true lumen, if you look here, is what the artery normally should look like and where the blood normally flows through, and the false lumen, where you have this hematoma or bleeding that's bleeding into the artery. And it's creating this kind of pseudostenosis. It looks like a stenosis, but it's really just that hematoma that's encroaching on the artery. Yes.
Could you explain what the little bullseye thing is?
Yes. So the bullseye is the catheter itself. That is a catheter within the true lumen of the artery. Yeah. So this brings us to kind of the classifications, and we've talked a little bit about this already, but type 1 SCAD is classified by being able to see that radiolucent kind of dissection flap. This is the easiest one to pinpoint on the angiogram. When you see a flap, you know that you're dealing with a dissection or an artery that's been torn. But what we now know is that the majority of SCAD that we don't see a dissection flap. It's actually more of a stenosis or a blockage type appearance. And that's why some of the other imaging modalities are more helpful in us being able to identify SCAD versus just a blockage. So in type 2 SCAD, it's long, it's diffuse, it's a smooth narrowing. It's not a focal narrowing. It kind of tapers. And that, again, is when the muscle is bleeding into the heart, into the artery wall, and it's narrowing the artery. To us, it appears like a blockage, but really it's just narrowing because of that bleeding that's encroaching on the vessel. Type 3 SCAD is when, rather than having a long, smooth narrowing where that hematoma has extended down the artery wall, you have a focal area that appears more like a blockage. And it's just a small area of the artery that's encroaching in on the vessel. So we've done the angiogram. We've seen these. Sometimes we use the IVUS, the intravascular ultrasound. We've diagnosed SCAD. What happens next in the cath lab? So generally, when we've made a diagnosis of SCAD, the best thing to do is to leave it alone. This is for a whole host of reasons. One of the biggest reasons is SCAD tends to heal. It's a bruise. It's a disruption in the artery, and our arteries are very smart. They learn to adapt and they learn to heal. So in about 70 to 97% of cases, if we do nothing to the artery, it will heal up. And oftentimes, even if we bring people back to the cath lab and take pictures again, that artery looks completely normal within about 30 days or so for most cases. Now, there is a small subset of patients where we can't wait because either they're too sick, that artery has that hematoma has blocked off so much of the artery lumen that there is no blood flow, or it's a major artery that's causing a lot of compromise to blood flow of the heart function. If people are very sick, if patients come in with a STEMI, an acute heart attack, and it's resulting in compromise to the heart, those are the situations where stenting is necessary to get that artery open. The reason why we don't stent everybody is because there is certain risk to stenting. So like I mentioned, this is not a problem of a blockage where you can go in and take a balloon and open up the blockage and place a stent in that area. It's bleeding, right? So there's a hematoma, there's bleeding into the vessel wall. If you put a stent in there, it can propagate, it can cause that hematoma to extend or get worse. And so because we know that SCAD heals on its own, the best thing sometimes is to leave it alone. But in certain severe cases, people do require stenting, and certain really severe cases where stenting is not an option because of that extension of the hematoma, bypass surgery or coronary artery open heart surgery is necessary as well. So this is just a picture, just to depict kind of the worst case scenario in a SCAD, when that bleeding, you see, you don't see a dissection flap. There's no flap, but there's such a narrowing, a smooth, long narrowing in that artery in the center there, if you can see right here. And there's an abrupt cutoff, meaning this artery should be flowing all the way down. And there's no blood vessels supplying this area here. So we know that this is a situation where maybe the patient might need an intervention, knowing that though, if we go in and put a stent in, there's potential for propagation. This is one of my patients, and unfortunately she was very sick. We couldn't get her chest pain free, and she was having arrhythmias. So we did opt to put a wire in the artery and place a stent there to open it up. So that's what the artery looks like after you've placed a stent to open it up. Thank you.
Okay, thank you so much for having me. I'm so sorry I can't be there. When a flight from the other country called California gets canceled, you end up on Zoom and you don't get to see Rebecca and Catherine and all of the colleagues that you work so closely with. So my name is Sahar Naderi. I'm the Director of Women's Heart Health and the Co-Director of the Pregnancy and Heart Disease Program at Kaiser Permanente, Northern California, based in San Francisco. I'm also one of the members of the National Steering Committee for the SCAD Registry, which hopefully many of you are participating in, and a very proud scientific advisory board member for the SCAD Alliance. And I'm here to talk to you about SCAD, the top 10 things I need to know outside of what all these other beautiful talks have discussed. So I'd say number one, there is a lot we do not know. So the knowledge is power, but I think our knowledge when it comes to SCAD only goes so far. So I wanted you all to know that, you know, I think a good cardiologist will tell you when they don't know the answer to many of your very astute and insightful questions. And that's why the SCAD registry and all the active research being done around SCAD is so important, because there are a lot of gaps in our knowledge. So this was my way of telling you that, you know, when your docs say they don't know, it's not because they in particular don't know. It may just be a situation where nobody knows yet. But we are hoping that as the years go on, we'll know more and more about SCAD and be able to fill those holes and those questions that you have. 2, the brain-heart connection is strong. So I think I wanted to point out that there are a lot of other organs in the body outside of the heart, although your cardiologists sometimes forget that. And your mental wellness and going before a SCAD event and your mental wellness after a SCAD event should be of paramount importance to your care team. I think, as you all saw, I'm a mom, and I think a lot of us sometimes put ourselves after our families, and I think that's just a lot of how the world works. But I think that these are situations when you're a SCAD survivor that your mental wellness needs to be very, very closely paid attention to. And if you have needs for a therapist or a psychiatrist or anything that you think, sleep deprivation, there's components of your wellness that have been lagging, I think those are the things that we can actually intervene on at this point, since there's so much about SCAD we don't know. So remembering that your brain is closely linked to your heart and heart events is really important. 3, this kind of segues from number 2, but you are more than just your heart. So I think a lot of my patients will say, you know, after a SCAD event, SCAD survivors are often told, well, you can't do this and you can't do that. But the question should always be for your doctors, well, if I can't do this, then what are my alternatives? And I think that speaks very well to potential exercise restrictions after SCAD, medications for migraines, medications for ADHD, talks around hormones and reproductive health. And so I think when someone says no in terms of things you can and can't do, there should be further questions of what the alternatives are. Because again, you are more than your heart. There are a lot of other parts to you. So making sure that the whole of you is healthy is just that much better for your heart. 4, I just wanted to throw out the social media pros and cons. Obviously, you know, social media is everywhere and is very powerful and can be very helpful. So I'd encourage everybody in the audience, should you want to be on social media, to channel the strength of what's worked and maybe not worked for your fellow SCAD survivors, but also take the things that you draw from the interweb and perhaps bring those resources back to your doctors to talk through just whether the recommendations you're hearing out or the buzz you're hearing about can be put in the correct context to make sure that it's relevant to you. So I think just being optimistically cautious about your use of social media. I do also have some patients who feel a bit triggered after their SCAD events going into the social media world too quickly. So I think just doing some soul searching about whether that aspect of the world right now is in your best interest or not, in terms of where your headspace is important as well. 5, SCAD might not be as rare as we think, and it can touch all of us. So I wanted to give you a little bit of data from our Kaiser Permanente data set, just to kind of put that in perspective. We've also published research, the Southern California group and the Northern California group, that reflects these statistics. But we have about 1,100 patients within KP Northern California. We are about 25% of the health insurance in Northern California. So if you do the math, let's say there's about actually 8,000 SCAD survivors in California. And so we're probably talking about a condition that affects tens of thousands of patients. Granted, we don't know the exact numbers, but I just wanted to throw out there that it might not be as rare as we think. Within our own registry, about 10% of our SCAD survivors are men. And it also seems to impact all races and all ethnicities. About 50% of our patients self-identify as white, about 15% as Asian Pacific Islander, about 15% as Black African American, and about 20% as Latinx. So I just wanted to throw out there that, you know, it really can touch all of us. At every corner of this country. And so, you know, I think you can look around the room and see that there is a diversity of those of us affected, or those of you affected, I should say. You do not have to just live with symptoms. So I think I hear this from patients that I get referred to a lot, which is, I have chronic chest discomfort or chronic migraines or other symptoms that might have been present before the SCAD event or came on after the SCAD event and have been compounded. And no, you don't have to just live with them. While sometimes we can't get folks pain-free, there are a lot of medications in our arsenal that we can use to get people feeling better. So I'd say if this sounds like you, there just needs to be a push to find usually a women's heart health specialist or a specialist in microvascular dysfunction or SCAD who can help find a concoction. I like to call it the Goldilocks concoction to get you feeling better. 7, access to supervised exercise is a complex challenge. This is a really tough one, and I wanted to bring it up because we talk about cardiac rehab a lot within our world. The the truth is, supervised exercise in this country is very, very expensive. A lot of big cities don't have the real estate to handle it, meaning just the physical space to handle cardiac rehab. And so, my recommendation to you all who might not have good access to supervised exercise is to do your research in your local community to see what centers may be providing supervised exercise, what their wait times are. I think with COVID in particular, the wait times have gotten exceedingly long and the chances of getting in are very challenging. The other thing is, cardiac rehab is supervised exercise for cardiac rehab is kind of an 8 to 5 opportunity. And a lot of folks work and can't kind of hop over to cardiac rehab during the day. So the alternative, I think a lot of places have pivoted to some form of virtual supervised exercise. So I'd encourage you all, if you haven't been able to access, the supervised exercise of cardiac rehab that we all love so dearly, to think out of the box in terms of how to get back on your feet, how to trust your new body, how to get back into exercise in a graded fashion. 8, genetic testing is not for everyone. I think this is going to be spoken about in the next talk, but just very briefly, while there's a lot of research on fibromuscular dysplasia and spontaneous coronary artery dissection, and there's some suggestion of signals towards genes that may be involved, there's no gene for SCAD at this point. However, there are a smaller group of patients who may fit a connective tissue condition related to a genetic vascular issue that has a known gene. And so a small subset of patients based on personal family history or the way their vasculature appears may be candidates for genetic testing. 9, there does not have to be a quote unquote trigger. I just wanted to point that out because sometimes, we're searching, trying to find what might have contributed to SCAD event, and there doesn't always have to be a trigger for these events. And I think that almost makes the scenario harder because you can't hang your hat on anything that might be modifiable to decrease risk going forward. So I think that points a lot to the fact that a lot of things that happen in our bodies are related to genetics, even if there might not be a quote unquote gene identified. And so there's just a lot we don't understand about what causes these events and causes them disproportionately in women. 10, we promise there is a reason we push those beta blockers. I just want to point that out because, no woman ever has liked their metoprolol, atenolol, carvedilol. Some people are okay with their nebivolol, but we really truly feel there might be a signal towards decreasing risk recurrence. And because medical therapy for SCAD is still really unclear, it's the one thing we can hang our hats on. There's also some data that it might decrease the burden of post-traumatic stress disorder in after SCAD. And so I promise you, your docs aren't throwing those beta blockers at you for no reason. So I just wanted to kind of highlight that because it becomes such a difficult thing. Now, that being said, if you're having symptoms with the beta blocker that you're currently on, there's a lot of different formulations, and one size and one dose doesn't fit all. So I would encourage you to speak to your cardiologist about switching doses, sometimes getting creative and taking them at night instead of during the day because they can make you kind of sleepy, helps you sleep through the night. So there are some creative ways of getting around that and making sure you can tolerate some amount of beta blocker. This is just a picture of my female all-colleague team, and I just thought it was all cool that it was cool that everyone in the cath lab that day was a woman. So yes.
All right, so I think our next speaker is Jason Kovacic. Did I say your name right? Jason graduated from the University of Melbourne Medical School in 1994 and then undertook residency and cardiology training at St. Vincent's Hospital in Sydney. He then completed a PhD at the Victor Chang Cardiac Research Institute before relocating to the U.S. To the National Heart, Lung, and Blood Institute at the NIH in Bethesda, Maryland. At the NIH, he undertook a postdoctoral fellowship with the director of the NHLBI, Dr. Elizabeth Nabel. He currently holds the position of the Robert M. Graham Chair and Professor of Cardiovascular Research at the University of New South Wales and continues his appointment as Professor of Medicine at the School of Medicine at Mount Sinai. And I think he's going to talk to us today about the genetics of SCAD.
Hi, how you going? Good morning. Here we go, genetics. You ready? Let's give it a go. So I'm pleased to be able to speak to you about this. And I got into the genetics of all of this over a decade ago when I finished my postdoc at the NIH. And the SCAD and FMD were clearly the most common diseases in cardiology, which we knew nothing about. And so that's why I started doing this. I looked at this last night and thought, my God, this first slide looks pretty scary, but we're going to get through all of this and we're going to make sense of all of this and sort of come down at the end to just some simple takeaway messages. So if it gets a little complex in the middle, hang with it because it's going to get real, it's, you know, simple stuff, takeaway messages at the end. So this is what I want to cover today. First, before we get into genetics, just this concept about SCAD and FMD are related. And I know you've heard about that before and you knew about that before you came even, but I just wanted to explain a bit more about how they're related and why we know they're related. I'm going to just talk about the first gene we ever found related to FMD and SCAD called PRACTA1, because there's a few good things we can draw out of that and learn from PRACTA1. Then I'm just going to talk about a couple of different types of genetic inheritance that are relevant to SCAD, and we'll step through that pretty slowly. So let's dive right in. So let's start with this concept that SCAD and FMD are related and this thing about collagen and matrix. So I started research on FMD and SCAD when I was in the cath lab well over a decade ago. I think it was about 2010. And a SCAD patient came in and I was on call and did the procedure and she actually had SCAD and we took some pictures of her kidney. She had FMD and I thought, oh, there's just so much we don't know here. I need to research this. So that's when I got into it. And we had this emerging understanding back then, this is 10, 15 years ago, that SCAD and FMD were related, but it was this publication that really first nailed it from Jackie Saw in Canada with 50 patients. This is a decade ago now when this was published, but the knowledge had started emerging around 2010. A single center study of 50 of her patients, mean age was 51. I discovered to my horror last night there's a typo here, and I've been showing this slide for a couple of years. But they all had heart attack from SCAD, and only one of them was post-pregnancy. So the key message here was that, 86% of them had FMD. Now we know this is an overestimate now, and probably the real incidence of FMD in SCAD is around 50%, depends on which study you read, but about half of people with SCAD have got FMD if you look hard enough. And I think this study really solidified this concept that FMD and SCAD are interrelated. So FMD has all these manifestations, and Daniela Kadian-Dodoff, my colleague, may have shown you this exact slide about an hour ago, that FMD has string of beads, focal stenosis, but it also has dissection. Just as SCAD is a problem of the coronary arteries being dissected, so is FMD. It can dissect carotid vessels, renal vessels, and other vessels, and there's aneurysm and tortuosity as well. But what we've known about FMD for a long time now, this is a picture from 1975. What we've known about FMD for a long time is it involves problems with collagen and matrix. And I want to just spend a little time on this collagen and matrix thing because it is important and it's relevant to the genetics of SCAD that we'll come to. So FMD was first described almost 100 years ago. And these are pictures, because FMD used to be managed by surgery, so they'd go in and they'd try to reconnect arteries, and there wasn't balloons and angioplasty and stenting and things that we have these days. Back in the 60s and 70s, FMD was managed only by surgery. So we got lots of tissues from FMD patients that were able to be analysed through microscopy, as you can see here. And we came to understand that FMD involves changes in collagen and matrix. Collagen, you can see there is a protein that provides structure to tissues, and matrix is very similar. It's the proteins and molecules that surround cells to give them their support. So, you know, when you pull up your skin and it has that sort of characteristic, it goes back down, that's collagen and matrix that gives skin that sort of little bit of elasticity around it. This is just a schematic illustration of a tissue, and that tissue might be skin or gut or artery. And you can see there at the top is the specialized lining. So for the skin, that's the epidermal cells. For the artery, it's things called endothelial cells. But underneath that, there's a whole bunch of collagen and matrix that's at work. So you can see that there's this lining of basement membrane, which is a matrix. There's these collagen fibrils. There's matrix between cells. And I'm sure you've heard about these collagen replacement skin creams you can get to try and preserve the aging of your skin. That's all related to collagen and matrix. So these are proteins, these are factors we know are involved in FMD. So it's very logical that these same things, collagen and matrix, are probably involved in SCAD at some level. We'll come back to collagen and matrix as we go. Let's talk about PRACTA1. This is the first gene we ever found associated with both FMD and with SCAD. So this was a decade ago, basically, 2014, at the first international FMD meeting that was hosted. Esther was there, Heather Gornick. This was in Cleveland. And Nabila, shown there with her lab, came to us all with this discovery that she'd made where there was this single gene change in this gene PRACTA1 that she'd found that was suggestive of being involved in FMD. Now this plot here is called a Manhattan plot, and I'm sure you can figure out why it's called a Manhattan plot. And what she'd found is if you get a point that's above this line, it reaches scientific significance. And she'd found this single gene change. This is like a street address. So I live at 81 Belgrave Street in Bronte in Sydney. This is like a street address for a gene. And at this particular street address, there was a genetic difference that was almost significant for being involved in FMD. And she came to us and said, I've got this thing. Who else has got some DNA, and who can help us to make this a real scientific discovery? So we did that. We all pitched in our DNA that we've been collecting, came up with over 1,000 FMD patients, and actually proved that this single gene change in this gene PRACTA1 was linked to FMD. So we did some microscopy studies, and this was actually using samples that had been collected in the 70s and 80s when they did surgery. We found that this PRACTA1 is present in the vessel wall, and particularly in smooth muscle cells. So smooth muscle cells are the main type of cell in the vessel wall. You can see that sort of that darkish chocolate color brown is this PRACTA1 signal in both the healthy vessels up the top and the vessels affected by FMD down the bottom. So we had this genetic signal, and we also had this localization of this PRACTA1 to the vessel wall. So this was published in 2016 as the first ever gene associated with FMD. So because we knew FMD as SCAD and SCAD are closely linked, it was a no-brainer for us to immediately collect all the people that were working on SCAD genetics and go, let's just look if the same gene, the same genetic street address is also linked to SCAD. And so we did exactly that. Similar group of people. 2019, we published the first gene ever linked to SCAD, exactly the same gene, PRACTA1, same street address, same gene, pretty much the same story. And the power of the linkage, the effect of the gene was exactly the same between SCAD and FMD. And what was, pretty cool, I thought, about this was that we also, by making this link, also showed that there's common genes involved in FMD and SCAD. And I think that adds some weight to our thinking in the way your doctors approach FMD and SCAD, because we know they're clinically linked, but we also now know that there's genetic links between FMD and SCAD. So this was a pretty important couple of papers that really, I think, showed the road forward. Now, this is where it's going to get a little, sciencey, so hang with it. Only a few slides like this. This is where it's, really gets interesting for us, and there's a hidden little bonus positive message for you coming up. So tune in. So it turns out at that street address in the gene PRACTA1, you can have two possible changes at this street address. So you can have like a high rise or a low rise, right? If you've got this specific type of gene change at this street address, which is called the AA, you're more likely to get FMD, SCAD. You're also more likely to get cervical artery dissection. No surprise that separate studies, separate scientists had shown that. You're also more likely to get migraine. You're also more likely to have hypertension. Same gene change, same street address, same gene. Now here's the twist. If you have the opposite genetic change at that street address, you're actually less likely to get FMD, SCAD, cervical artery dissection, migraine, and hypertension. You're more likely to get hardening of the arteries, coronary artery disease, regular heart attack. So what all of this science shows us is that there's actually a genetic arrangement where if you've got SCAD and FMD, most patients are actually going to be less likely to get a regular heart attack or atherosclerosis, hardening of the arteries, coronary heart disease. It's all the same thing. So this opposing relationship is actually borne out across other genes that we've now discovered. So that's my little bonus message for you, is that for most people with SCAD, not all, there are some exceptions, but for most people with SCAD, particularly sporadic SCAD that just arises out of the blue, you're probably going to be less likely to have hardening of the arteries or coronary heart disease or a regular heart attack, all the same thing in your lifetime. And that's actually genetically evolved that way. So that's my thing for you. So let's talk about what have we actually learned about the genetics. So what does that PRACTA1 gene tell us? It's another Manhattan plot. So this is a paper we've just published. It's at one of the Nature journals. So what we've now done is collected DNA from about 2,000 people around the world. So my site, I'm from Mount Sinai, so Mount Sinai put in DNA. I'm now also in Sydney, Australia. We put in DNA, groups in Paris, in London, other sites from Mayo contributed DNA, Vanderbilt, Esther, we all put in DNA. Did this big analysis, and we've now, it's another Manhattan plot, found 17 genes which make the scientific cutoff. So here's our scientific cutoff line here, and you can see all of these genes, and you can still see my favorite gene, PRACTA1, is still one of the most powerful signals, which is it up here. No surprise, it's one of the more powerful ones, but there's a bunch of other genes that we've now found. So we've now got 17 of these common gene changes. And what's interesting here is that each of these gene changes only has a relatively weak effect on causing SCAD. And that increases your risk. Each of these gene changes increases your risk about 1.5-fold. So but there's lots of them, right? We've got 17 here, and there's probably more of these yet to be discovered. And what's interesting is that the genes we discovered were often involved in collagen and matrix. And you can see here, there's collagen 4A1 here, collagen 4A2. Other ones in here are related to the collagen. They just have got weird names. But collagen and matrix is coming out as one of the causative mechanisms of SCAD. So that's very reassuring to me and my colleagues that we're on the right track with figuring out the genetics here. So common genetics is what causes us to be who we are. So the fact that I'm 6'8" tall is a bunch of common genetic changes. Our hair color, eye color, body size, all of these things are due to common genetic changes. And we've found that it's these common genetic changes are mostly what underlies SCAD for most people. These are not considered mutations. And in fact, for that PRACTA1 gene, 50% of the population has the SCAD or FMD risk type. So 50% of us in this room, whether you've had SCAD or not, have got the SCAD risk type. 40% have got a mixed, and 10% have got the strong risk factor for atherosclerosis or coronary heart disease, and they're somewhat protected against SCAD. So what's going on here? It's this balance that you inherit when you get your genetics. There's many genes involved, each with a weak effect, and these are common genetic changes. So you notice I'm not using the word mutation or things like that. These are common gene changes that we all carry across the population. And it seems that this kind of genetics is the basis for most of SCAD, not all of SCAD. What also came out from this big analysis we just published is, as I've already said, SCAD is proven to be linked to an increased risk of FMD through genetics and migraine, but a reduced risk of coronary artery disease or atherosclerosis or regular heart attack. So again, we've proven that if you've got SCAD, you're less likely to have a regular heart attack. So that's the positive message clearly in all this. All right. I've been very careful to say this is the genetics for most. In a minority of SCAD cases, there probably are rare gene variants, or you could call them mutations. I don't like to use that word, but I just want to show you one example of these rare gene variants that we've found. So this was a study we did in Sydney, and there's been a couple of other studies like this out of the Mayo, out of Mass General with similar findings. We took 91 unrelated cases of SCAD and looked for rare variants, rare gene changes. And here we go. We found these rare gene changes, again, in a bunch of collagen and matrix genes. And you can see there's all the scientific mumbo jumbo there about what the gene change is and all these other factors. But the reality is that around 11% in our study of SCAD cases had a gene variant. So they had a single gene change, which was having a strong effect in causing them to have SCAD, rather than a whole bunch of, 17 genes having a mild effect. So to summarize this study that we did, from 91 SCAD cases, we found 10 that had a gene variant. And this and other studies suggest that the genetics of SCAD usually involves these common gene changes like PRACTA1, but in a minority, there's a gene variant involved. So let's bring it home. Last slide. So save it to the end. 10 points for you. Top 10 that I wanted you to take away on the genetics of SCAD. There are clear genetic links between SCAD and FMD, like PRACTA1, but there's actually a bunch of other genes that are shared between SCAD and FMD, and that's why your cardiologists and physicians, sometimes you'll see them thinking about these diseases as almost the same thing, because maybe to some extent there's so much overlap genetically that that's the right way to think about it. The genes linked to FMD and SCAD mostly affect collagen and matrix, those proteins that hold cells together, hold tissues together. They're responsible for your skin integrity, all sorts of things. They are likely the most common genes involved in causing SCAD and FMD. For most SCAD patients, there are many common gene changes involved. Each of these common gene changes has a weak to modest effect on increasing the risk of SCAD. And we've so far identified 17 of these common gene changes, but there are likely to be more. Just a side point here, the ones that we've found so far are the ones that stick out the furthest, right? So the ones that we haven't discovered are going to be even weaker in their effect, and that's why we're yet to find them. We need to get more subjects, more people in our studies to find the weaker ones, but they're going to have even weaker and weaker effects as we find more of these genes. Because each common gene change has a weak effect, there are likely to be more SCAD gene changes we haven't discovered. It's not yet possible to do genetic testing for SCAD at this time. So this is for most people, right? Because of this, complex genetics, these common gene changes, many genes involved, it's not practical or even possible to do genetic testing for SCAD for most people. Point 7, a minority of SCAD cases may be linked to rare gene variants. And this is the challenge for us as physicians, is to figure out which of the SCAD patients we should be looking for those rare variants in, and which are the ones where it's not worth it and we're going to find nothing. And so some of you will have had genetic testing, some of you won't. But this knowledge that SCAD is through this mix of complex genetics, and some of them will have rare variants, some won't, is why some of you have been tested, some won't. And that's very much a conversation you need to have with your doctors about, should I be tested for rare gene changes, vascular gene changes that might be causing my SCAD, or do you just think I've got common sporadic SCAD and nothing to be done? All right, a couple of bonus points here. If you have had SCAD, you are genetically less likely to have a regular heart attack from coronary artery disease. So it's an important positive to take away. We are working like crazy to identify more SCAD genes and to understand those genes that we've already identified. And I can tell you my lab in Sydney is totally devoted to studying this PRACTA1 gene, the first gene we ever found. And we've got all sorts of models and cells and things we're doing around that. And I'd finish by saying, just 5 years ago, we knew nothing about the genetics of SCAD. We didn't even know what the basic framework was for the genetics. We've learned a massive amount in just 5 years. The progress is fantastic, and I'm really excited about what we're doing in this space, and I hope you are too. So thanks very much. Happy to take any questions.
All right, welcome back in. I am gonna start moving us along. I know this was a really good opportunity in all the groups to get some discussion, and I know people are still trickling back in, and that's totally fine. I think that's one of the really neat and special parts about getting together in groups like this, is being able to connect with people. And so I'm excited for that. I do want to make sure that I do a little bit of wrap up from the groups, just so we can keep going with the afternoon. We have some more great discussions. So what I wanted to do is just have I'll moderator, or if there's somebody else in the group that should talk, just kind of a couple points about maybe some key takeaways or things that you discussed in your group. And so the first group, first only in order of here, everybody's important. The first group that was on here, group A, the more newly diagnosed. And so Maureen and Rebecca, Val, I didn't know if you guys wanted to just turn on your mics and share, 2 or 3 points or kind of some key things that you all discussed. I'll type them up here. You got to be really close to your mic. Nope.
Can you hear me?
Yes, I can hear you, Rebecca.
Well, you can jump in, Maureen, but I think the main things we talked about were the importance of accepting help, particularly in the first few months, the first year of recovery, and how women in general, we don't tend to be great at that. And just having a lot of grace and self-compassion in that process is really, really important. Some of the folks who had been through this a little bit longer shared, how important that was for them. A couple of people talked about chest pain. How long does it last? What's normal? kind of along those lines too, the value of utilizing cardiac rehab if you can, just to sort of regain some confidence in what you can do physically and just getting confident in your body again. What else?
The other important thing was how to say no.
Oh yeah. Oh yeah. How to
no.
say no. So setting boundaries and limits and yeah, using this time to really recover physically as well as emotionally.
Awesome. Thank you for sharing that. Definitely super important things. And I think probably all of us in the room, I think that's just highlights again the value of coming back as a group to talk about these things, really important where we're at, but especially at the beginning point. So group B was caregivers. And I know you all had a lot to discuss, which I'm so glad. Were there a couple of main points?
Sorry that the caregiver group was a little late to come back.
That's okay.
Which speaks to the first point that I would like to share is that there is a need for more caregiver supports, more materials, more groups, more connections for caregivers to be able to share their concerns and get support, peer support, as well as professional support. Another top one is information that can be shared with family and friends, not with the survivor, but with family and friends, that explains that it's not the caregiver's fault. The caregiver feels responsible in a lot of ways, whether that's for the actual event and, could they have done something differently to prevent it? We explained that it's not their fault, but the feeling of fault and or that they don't know how to or don't feel that they're being the caregiver that they want to be and don't know how to be a caregiver. So having more tools accessible to them that they can also share with their support system.
Definitely. Makes sense.
And then kind of being involved with a cardiac rehab came up as one, having specific cardiac rehab and maybe getting involved with their partner, significant other, the person that they're caregiving for, to be involved with healing and moving forward on something that's specific to SCAD.
Definitely.
And because it is different. I think we've discussed that before.
Yeah, no, I could definitely see how that could be part of that cardiac rehab, that, healing part.
Yeah.
So nice. No, again, definitely important things. And again, I think good for all of us to see those and realize the burden. And thank you, to all the family members and loved ones and friends who are here supporting, and even that can't be here.
And I'll just add the one that we had at the very end, talking about how frustrating it is to find cardiologists who know SCAD, know what this is, and are connected to this network. So continuing to add where the centers of excellence are, who those doctors are, and how to connect with them.
Absolutely. And I want to make sure I type this in here under this caregiver point, because I think it really ties into the family members as well, not just the patient or the survivor.
Yes. Can I
Thank
just
you.
ask the caregiver group, the sheets that we filled out, if you could just drop those off? A lot of you walked out with them. If you wouldn't mind passing them
yes.
back at some point today, we'd appreciate it.
The forms, hand them back to Rachel, please. Awesome. All right. In the third group, you all talked about really next steps and kind of advocacy and support and kind of what's next. How do you, what do you go from here? So Nisha or
I'll take that one. So one of the things that we discussed during our time together is mental health. That was one of the key things that came up, and we discussed that it was hard to get not only doctors who were familiar with SCAD, medical doctors, but also it was difficult to get doctors who understood the minds and the way to support a SCAD survivor or family member. One of the things we talked about was also on-call support. Another thing we talked about was everyone needing someone to contact or someone to be a person just to encourage either a caregiver or survivor, and for it to be someone that's been through the same thing or something similar. Finally, we had the opportunity to share that we do have several regions already, but another thing is, and the final thing is that having a region specialist in every region that is knowledgeable about SCAD and that knows what to do and recognize when they see a person or have an individual who exhibits symptoms of SCAD. And I also want to just say a lot of what we talked about could be found on our SCAD Alliance webpage. So we did have the opportunity to take them to that, to the support toolkit, and also the media. So some of that we were able to pull up for them exactly, and they have a card that has our SKU on it, so that if they are in a situation where they need to share with their doctor about SCAD, that will take them directly to it.
Definitely. That makes a lot of sense, being able to have those resources. And then the continued piece, I think some of the things I see definitely through here are having, let me see if I can make it smaller. I don't know if I can. I'll just scroll up and down. But have, that emotional support, that mental support throughout the entire process, right? And for all of us. I mean, we could probably argue that everybody in the whole world needs that, but especially after going through something so significant. And so as individuals, how can we, I kind of challenge us as we all go forth from here, not yet, end of the day, tomorrow, actually next week, once you digest things from today, as individuals, how do we build that connection and get that support and foster that support, but also when we're ready, taking that to build those networks, in our areas and in our own cities. And then, I know we'll talk more about SCAD Alliance and iSCAD registry, later on this afternoon, but how we can utilize those, centers to really keep building these things. So thank you guys so much for sharing and, for participating in the groups. I'm really excited that we were able to build this in and have this time to work together. So thank you.
So it's my pleasure to introduce Dr. Wood. I guess before that, I should introduce myself. Hello, everybody. Brian Wells. I'm a cardiologist and vascular medicine physician from Emory Hospital in Atlanta. And it's really nice to see everybody today. I know you have a lot of smart physician scientists upstairs doing a think tank incubator and are on the edge of discovery to imagine ways to better diagnose and treat SCAD. And as other people have probably told you in this setting, this is the quintessential example of research and support and community being supported by patients. So this is a really good example of that. I appreciate you all being here. And with that, we're going to move on to our next session. So Dr. Wood, you just saw, and a colleague of mine, she's from Mass General Hospital, cardiologist, and we've worked together through iSCAD, and she is a leader and a pioneer in women's health, and was one of the early leaders in SCAD research, education, and patient care. We didn't get to work a lot together during the pandemic, but fortunately with conferences like today, we're able to network and interact with our colleagues, and it's been really nice working with you. And that one piece that I wanted to tell you guys in terms of the format of this session is going to be slightly different. A few people have to start leaving for flights to travel. So for the questions, we're going to do 5 to 10 minutes of questions after each talk. So that'll be so if you have some questions for that speaker, be ready, and then we'll move on. And we won't do the panel discussion at the end. That'll be the only difference. So thank you, Dr. Wood.
So, hi, everybody. I'm Melissa Wood, and I would like to take a survey. So how many of you completed cardiac rehab after your event? Awesome. How many of you were the only SCAD patient in your cardiac rehab? Yeah, so I figured, yeah. How many of you were the only woman in your cardiac rehab? For those of you that are women, okay, all right. So I am going to talk a little bit about sort of stress from the perspective of how it might have led up to SCAD, a little bit how that's incorporated into cardiac rehab, physical activity, and then kind of recovery after SCAD as you go back into your routine. And I will say that even at this conference, I've learned some really new things by talking to my colleagues, but we wouldn't be here without all of you. And of course, Catherine, Rachel, Rebecca, all of those who've really stepped up and led the way in the SCAD Alliance. And so I'm so grateful to them for leading this group, because I think it's not only has it brought so much support and relief to patients, but the fact that I was just 4 floors up with some of the smartest people in the world, and the ideas, the innovations, the way that we're going to continue to really disrupt medical care, because we think that the way care is being delivered right now may not be the best model of care. And so we want to continue to really try to innovate. And the best way to do that is by incorporating our patients' voices. So we had some physician scientists. Your voices are going to be part of it. And then hopefully down the road, we'll be able to make a real difference, to continue to make a real difference. So I'm just showing this. This is an abstract that we presented at one of our scientific meetings recently. And this is from the iSCAD registry. And I show this because it's really talking about the triggers and the things that can lead to SCAD in our patients. And, you know, we ask people about underlying conditions, and you're going to hear a bit from Dr. Wells about, you know, migraine headaches. And we know that these are some of the conditions, but I really show this because it's very important to recognize. And this is, these are diagnoses that existed prior to your diagnosis of SCAD. And I think that's critical, because I think we all understand that anxiety and certainly depression can be present in all individuals after you have a heart attack, particular heart attack due to SCAD. But in fact, if you look before, over a third of patients actually had a pre-existing diagnosis of anxiety when they presented to the emergency room with their event or wherever you presented. And that's really important, because I can tell you, up until quite recently, when a young person or a person who doesn't have traditional risk factors for heart disease shows up in the emergency room and there's anxiety written on their chart, the lights go down. And I mean, and I hate to tell you this, but this is the bias that exists in our medical system that we have worked very hard to address. And that's by helping medical professionals understand that anxiety is deeply rooted in many types of cardiovascular disease. And it's actually really a factor that should be considered one of those things that we have to treat and prevent aggressively, or treat to prevent cardiac events. But clearly something that was present in a lot of you before the diagnosis. And then we look at things that might have occurred in your life, either immediately or chronically on a regular basis before you had your SCAD event. And I think because I take care of a lot of patients, I know that many of my patients are teachers, many are nurses, many are mothers of children who have a lot of either physical or intellectual challenges, people who have a very difficult home situation. And so it's no surprise to see that stress was a significant part of someone's experience before SCAD. And actually looking to see that almost half, 40%, reported some type of an intense stressor that happened in their life before. And I just show this because it's critical when you think about recovering from an event. If you had that event in the setting of something really stressful happening, doesn't mean there's anything wrong with you. It just means that your body's adaptive mechanisms might have been a little bit exhausted. And so, you know, like the marbles were out of your jar and we're trying to put the marbles back in your jar so that you can be more resilient going through your life. And then with regard to exercise, it is important to know that some people who have SCAD reported vigorous exercise, but actually the majority didn't report that it was something super strenuous. And those who did, it was more like more physical, like running, doing something vigorous with an aerobic point versus lifting. But in the Mayo series, actually, men who had SCAD were more likely to report that they'd lifted something very heavy or had done a very exhaustive lifting workout prior to their SCAD. And some of the reasons that we think physical activity could contribute to SCAD, First of all, it's physical activity occurring in someone who has a predisposition for SCAD. So being peripartum, having FMD, having some other condition that would predispose you to SCAD. But acutely, when we exercise, we know that when we bear down or squeeze Valsalva, that we actually raise our blood pressure very, very high. And we saw a slide yesterday by one of our presenters that showed that when a weightlifter actually does a squat and lifts their blood pressure can go over a 400, believe it or not, when they're lifting. And so that kind of a surge can put your blood vessels under a lot of stress and make them more prone to injury. And, that surge can also be associated with increases in our body's adrenaline, and adrenaline causes your heart rate to go up, your blood pressure to go up. It can cause your blood vessels to either not open up the way they should when they need to, or to even have some decrease in the caliber or some, spasm. And then, when we think about those things like the exercise, like the activity or the anxiety, predisposing to SCAD, we know after SCAD, the anxiety is very common, right? So everybody has anxiety because you had a heart attack. If you saw a doctor who knew about SCAD, maybe your anxiety was alleviated a little bit. But if you saw someone who wasn't familiar with it and said, I don't know why this happened, you walk out of the office thinking, wow, if you don't know why it happened, then you certainly can't tell me it's not going to happen again. And I think that kind of ambiguity makes people very anxious. Now, we feel good because we know that there are a lot of things today we can tell you to help you feel more confident when you leave the office. But as someone said, people like us aren't everywhere. And so, we want to be able to be more available to patients who need us, especially in remote areas, so that we can alleviate some of that anxiety and depression after SCAD. But we do know that cardiac rehab is a great way, if you're in the right kind of program, to at least begin to understand and address the anxiety that does exist after a cardiac event. If we look at the data, we're cardiologists, and so we look at data and we look at data, how does it predict things? And, we know that in general, for all forms of heart disease, that stress level does increase the risk of cardiac events. And I think most of you have heard about broken heart syndrome or stress cardiomyopathy, Takotsubo, and that's like a direct impact of that high level of stress. So we really want to help you mitigate or manage stress. And I show this figure just because, and I know it's written from a medical journal, but the point here is that anything that drives up your adrenaline is going to really make your body's response to an acute stressor abnormal. And in the setting of sort of a sudden stressor on top of a baseline level of anxiety and stress, it can even be more difficult for you to handle that type of an event. So we know that when you have, you're in the hospital, maybe if you're lucky, someone will talk to you about the stress you have before you're discharged. They may say, do you have a behavioral health provider? Some may even suggest that if you're really anxious, that you consider taking at least a short-term medication. And if you're really, really lucky, you'll be connected with people like SCAD Alliance, other patients who will really help also give you that support on top of the medical support that you need from your clinical providers. And these are some of the things that we know can really be helpful. We know that the mind-body interaction and managing that through mindfulness can help our body's health overall. It reduces our risk of cancer, heart disease, and other conditions. But learning how to be mindful and learning how to incorporate these types of mind-body practices, that's not something cardiologists are good at teaching. And so you have to find resources either through your cardiac rehab or through your cardiologists that people or your primary care that can help connect you with the right people. So when you get to cardiac rehab, these are some of the issues that you all have shared with us that really have kind of made the process of cardiac rehab a little challenging for you. From the perspective of you being patients, many of you are employed. The average age of SCAD in the US is about 44. You may have young kids or you may have parents that need your support, being in the sandwich generation, and you're very busy. And many of you don't have doctors that actually at the end of your hospitalization tell you you need to take time off from work. So sometimes people actually have to go back to work within weeks of their SCAD event. And so finding the time to go to cardiac rehab can be very challenging. Additionally, for those who provide cardiac rehab, there are no real clear guidelines for how we should create and modify cardiac rehab for SCAD. We have some new models, and I'm fortunate to be at a place where we have a really outstanding model for SCAD, but it's not like every time you go into that cardiac rehab, there will be 4 or 5 patients with SCAD. You're kind of on your own doing a different form of cardiac rehab than everyone else. And so I think we really need to understand how we can address the unique needs of the SCAD population. Mayo Clinic did create a unique SCAD model as well and wrote about it. Didn't have a lot of patients, but they did follow them, and they found that this unique approach to cardiac rehab after SCAD helped patients do more activity. It helped them be in better physical shape. Some of them, they actually lost weight and they had improvement. When it says depression and stress scores increased, that's actually favorable. That's a good thing. It doesn't mean they were more depressed and more stressed. They actually felt better. And interestingly, they actually used high intensity interval training as part of their cardiac rehab, which I thought was surprising because a lot of cardiac rehabs don't tell people not to do that, but they actually incorporated that into their cardiac rehab. And then Dr. Saw, over the course of time, has accumulated over 300 patients. But what I will tell you about the SAW program, there's a difference. Where is she? Canada. So in Canada, you can do ongoing cardiac rehab and not have to pay. If you have to pay, it's a minimal amount. So it's not like here where you get your designated number of visits and then boom, you're out on your own. In Canada, you can keep going. And so I think they have a more robust practice because, number one, they're a referral site for SCAD, but they also follow these people over time. And so, you know, if I kept every patient in my cardiac rehab that I've ever seen, it'd be way more than 300. But I think it's a way to sort of say that it's an ongoing process. And they did also look at stressors. They looked at physical activities. And, you know, they found that, you know, in that type of program, their patients actually had fewer visits to the emergency room. And what this kind of means here, if you look at the top, that means people going or having any type of event was like minimal, like no events. And then the black line is people that didn't have SCAD related cardiac events, and they actually had things. They weren't terrible things, but they were things like needing to go back to the hospital or needing to have more testing or another cath. And so non-SCAD cardiac rehab in their process was associated with more events than people who had SCAD specific cardiac rehab. And, you know, that's sort of important because it really gives us a way of thinking about designing a program. Now, this actually tells us that it's safe. I'm going to translate all that into like really the take home, which is in 3 different forms of cardiac rehab designed for patients with SCAD. And you can see one was really small, 9, one was larger, Canadian 269, and slightly smaller cut of that data was 48. But in these groups, what they found was it was very safe for patients to do cardiac rehab. They had no cardiac rehab related events. And so there weren't people having problems getting on the treadmill or any such thing. But I think it's really important that you work with your doctor or, you know, the people that you might counsel when you're a peer mentor to talk about the timing of cardiac rehab. So sometimes people are sent straight in. What we do is we talk to our patients and say, if there's a time when you're comfortable walking a mile and a half, you're not taking any nitroglycerin, you're not, you know, having chest pain with minimal activities, then we're okay with you starting. But I think it's important to know that you're ready for it. And it also depends on how you were treated. If you had a stent placed and your heart is now fully revascularized, you may be ready to start quickly. But if you were managed without a stent and you had a pretty significant blockage that's still healing, well, we don't want you to stress that. We want you to heal. And so that approach that's got to be very individualized is really, really important. Now, the type of cardiac rehab that really we'd like for people to do is 36 sessions with 1 to 3 times a week and really addressing all of these key elements: nutrition, mindfulness, stress management, you know, exercise, cardiovascular conditioning. And I tell all of my patients, SCAD was like this little opportunity for you to become a better version of yourself. And, you know, even if you were in excellent shape, maybe you were dealing with stress. And maybe if you weren't in excellent shape, you can get in better shape. And so I think everybody has a place in their life that they can make an improvement. And the goal of cardiac rehab is to identify those opportunities for improvement. And there are these two different models. We at Mass General have what's called an intensive program, and that's a shorter program, or it's 18 weeks, I'm sorry, longer, but it's 3 hours per week instead of the dedicated 1 to 2 times per week. And it actually is a lot heavier on the mind-body part, and a lot of discussion and sort of interaction with the intensive cardiac rehab trained staff. Not everybody has that. It's a special designation, and it's really popular with our SCAD patients, but it's not necessary. You just need people that know about SCAD in your cardiac rehab program, and if they don't, then you can help connect them with people that do. And I've always been willing to either work with cardiac rehab staff, the nurses who I love it because it's nurse run. There's a doctor who signs off, but they usually do nothing. It's the nurses that run the show. And like most things, it's really important that those nurses feel, and physical therapists and physiologists feel comfortable with SCAD. Now, I actually co-edited a book on sex differences in heart disease, and I'm not plugging it because it's a doorstop, but if any of you want it, I'll send you a free PDF because it's a great compendium of stuff, but it's written for medical professionals. But Dr. Tweet did make this figure, and I actually really like it. And it talks about sort of early in cardiac rehab, what do? You start really low, gradually increase, and then towards the end, they kind of say, well, what is it that your goals are from physical activity perspective? And then if you're really physically active before, they have you go to cardiopulmonary exercise testing, where they make a very specific heart rate recommendation for you so that you can get back into running, et cetera. And they really want it to be safe, and they want you to do the things that you like, but to do them with, I call, guardrails, right? So that limits that you need to follow. With weight training, and we learned this yesterday from Dr. Phelan here, it's less about the number or the amount of weight. It's more about what you're used to doing, what you like to do, what you need to do. There are weight things that are off limits. I tell my patients, if you like CrossFit and you like to bench 180 pounds and you're a 110-pound female, I don't think that's a great idea. And actually, believe it or not, I have one female football player, and I told her I didn't think that was a good idea either, because she was constantly getting hit with things. But creating an exercise program before you're discharged from cardiac rehab is really important. Having them fill out something that you can take home with you so that you can stick with it, and really to improve your exercise ability. CPET, again, that's something that I mentioned, cardiopulmonary exercise testing. That's like a stress test, basically, that gets a lot more information, and very important if you're someone who really wants to do more vigorous activity. Again, the strength training, they will give you specifics based on your interests. But the key things we tell people, avoiding high intensity exercise, like getting your heart rate into that red zone, avoiding highly competitive contact sports like football. Ideally, you wouldn't do that. Trying not to push yourself into exhaustion where you're not able to really speak when you're exercising. And the key thing here too is warming up before you go out and exercise. So if you're going to go jog, make sure that you've done a nice warm up so that your heart has a chance to accommodate to that. I personally do hot yoga. It's very, very stressful on the cardiovascular system. I do not recommend it for patients who've had any type of cardiac event, because you're going into a room that's 105 degrees and working out really hard. So probably not hot yoga, but yoga, downward dogs, planks, those are fine to, as long as you don't have physical injuries, but you want to do those after you've completed cardiac rehab. And then the Valsalva, which is where you lift and hold your breath, you want to be careful with that. So these are some things we recommend, talking about the things that are bothering you. That's called disclosure, journaling, writing down the things you're learning, creating your roadmap, learning how to do the mind-body stuff. And the goal is to decrease your anxiety, decrease your fear, and increase your trust in your body once again. And with that, I will stop. Thank you.
So I'll introduce our next speaker. And the next speaker and I just realized we have a connection. We're both from Augusta, Georgia, and we went to rival high schools.
He went to give me a fist bump till I told him which high school.
And I said, never mind. And you still live in Augusta? Okay. Well, all right. Well, welcome. I'll be there for Memorial Day weekend. We can hang out or something. No? See? So, Naisha Parks, your SCAD survivor, 24 years. And you actually 14 years a SCAD survivor, and thank you for being here. And you work for Columbia County. Okay, and what do you do for Columbia County?
Director of Teacher Development.
Director for Teacher Development. Okay, well, thanks so much. And you'll be talking to us about moving forward life after SCAD.
Yes.
And thanks again for being here.
And you can come see me more. Okay.
All right. First of all, hello, everybody. Hi. I want to talk to you just a little bit about moving on. I'm going to share a little bit of my story and where I started and where I am now, and then some of the things that I went through and the supports that I sought and received, and which led to the outcome that we have now, which is me being an advocate and also me just being available and ready to support the cause in general. So. Okay, we're not moving? I got it. I got it. I got it.
What about that there? Got it?
I got it.
How about this arrows too?
I got it. Okay, yeah. So I had my SCAD 10 days after I gave birth to my son. So I was feeling like most mothers, just feeling like I was cooped up in the house, and I called a friend and I asked my friend if she would come and take me to get a Diet Coke. She said, of course, like most friends would. And we did. Off we went. And so as I sat there talking with my friend, I started to feel bad. An indescribable feeling, really, nothing that I had ever experienced before, but it was still surely my intent to go home and go back to bed. So it was not a good feeling, but it was not something that alarmed me so much that I thought, well, I'm going to, need to go to the hospital, right? So I finished up my Diet Coke, and I told my friend that I felt bad, and I asked her if she would take me home, and she said yes. So I went into the restroom and washed my hands, still just kind of feeling the same. And then when I looked in the mirror, I was sweating profusely, like I had just run a marathon. And I'm that person who is, I'm the girl who goes in the gym and I go by the fan. And then I asked if permission to turn the fan right on my face so that I don't sweat. So I'm not, I'm not really a sweater. And so what happened is at that point, still, I would have gone home. Really, still, it was still my intent to go back home. So when we say know our bodies and recognize the symptoms, that's very important. And that's one of the reasons I enjoy speaking to patients, because I was about to ignore something that would have a tragic outcome. And surely, my children would not have had their mother and I wouldn't be here now. But I walked out into the McDonald's and I had a friend, I'm an educator, as I mentioned earlier, and her husband had several heart attacks. And it was like immediately I was looking at him and he was sitting over in his love seat and he was saying, when I was at the ball field, I had my first heart attack and I felt like an elephant was sitting on my chest. And immediately I knew, not because of what I was really feeling, I started to feel the heaviness, but I knew that something was wrong and that I couldn't go home. I knew that much at that point. So I went over to my friend and I said, hey, look, I'm sick. She says, oh yeah, I'm about to pull the car around and, you're going home. And I said, no, you don't understand. I'm very sick. So I can remember her hands just shaking. I said, call 911, because I was probably speaking to her just like I'm speaking to you. And I'm telling her to call 911. And she did. And I woke up almost a month later. Okay. So what was happening to me at McDonald's is I was having a pulmonary embolism. I did have a C-section. I was having a pulmonary embolism. I don't remember these 3 days, but I was in the hospital for 3 days. And my husband was where? He was home with the baby, right? So my mom and my sister were there with me, and I continued to complain of chest pain. And this is just all from what my parents, what my mom and dad and my sister told me. And the cardiologist said, she had a clot that was so big that this is just residual pain from her clot. I promise you that it is going to subside and go away, right? So that was on a Saturday. And on a Sunday, I woke up and I said, Mama, if you don't get something done, I'm gonna die here. I'm gonna die here. And so she did what any mother would do. She got the doctor on the phone. I think he may have been at Chuck E. Cheese, you know, with his kids. So, but he did. He came to the hospital, and he said, I am 99% sure that the embolism was so big that it is just residual pain, but I'm going to do a cardiac cath just for you. I'm going to do that. So he went in to do the cardiac cath, and he could not proceed because my arteries were peeling like a banana. My arteries were dissecting. And so immediately he came out and he said, we have to go to open heart surgery now. You know, her arteries were dissecting. I've never seen anything like it. And so there was a doctor who was on call, a doctor who did not know very much about SCAD, but committed himself to researching within that short period of time. And so we went to surgery, and he still then didn't really know much, but I got a triple bypass at the time. Well, he felt like I would need a new heart. So he got on the phone. He had a friend at Emory who owed him a favor. He thought, well, I've got this 35-year-old female. She's got SCAD, blood type. I need a heart. Well, they had a heart for me in Augusta, and I was a perfect match, but they wouldn't give it to me because they knew that, or they felt like, because what they knew wasn't true, obviously, they felt like I wouldn't make it, right? And you can't I wouldn't make it. And so they wouldn't give me the heart. So he called up his friend at Emory, and he had not heard back from his friend at Emory, but he heard back from someone in Colorado who said, we have a heart for this young lady. She's a match, but you're gonna have to airlift her. So then he had to decide, is she gonna make it? Will she make it if I airlift her? And his answer then was no. So now we're faced with another issue. We've got a heart somewhere. We've got a heart here. I can't have it. And then we got a heart somewhere in Cleveland. I can have it, but it's possible I might die en route. So he had to do what any physician would do, which is no harm, do no harm. So he kept my chest cavity open. He gave me a triple bypass, and he kept looking, and he kept doing everything that he could so that I would be able to recover. And so I remained in a coma. They closed my chest cavity up after a couple of weeks, and I remained in a coma for about a month, and it was a medically induced coma. But eventually my ejection fraction began to improve slowly, 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 until he was able to close me up. They couldn't wake me up out of the coma right away because every time they would, I would get upset. Because as far as I knew, the last thing I had said was, just take me home so I can go to bed and take a nap. So my heart attacked me, all right? My heart attacked me in the process of all of this. And then I had the SCAD. So that's my story. That's a small bit of my story. But what you should take from that as a caregiver or as a physician is that there are still great physicians in the medical field that have signed up to do no harm, and they will not do any harm. That's still true. I wouldn't be here if it wasn't. The tenacity of a mother and the relationship of a mother with her children is still a relationship that should be valued. Because I told my mother I was not going to make it. And what did she do? What any mother would do. She made it happen. So I want to encourage you, whether you're a mother, whether you're a caregiver, whether you're a doctor, whether you're a person who's advocating, be proud of yourselves, because there are many people like me. This is just my one story. This is just my one story. But if you look around this room, there are hundreds of people who are just like me. And for whatever reason, someone had to contribute to their success. So I want to thank all of you in here, because for those reasons, I'm here speaking to you today. Oops. I'm gonna do action steps. I'll just go there. So here's some things that I did. I can tell you that I was 35 years old. I had one daughter. My daughter was 10, and then I had my son. I was living, I guess what they would say, my best life. For a long time, maybe months, I was so angry. Although you hear me speak about the blessing and you hear me speak about the individuals who supported me and helped me, I was angry, and I was angry because my life had changed because my heart decided to attack me. And it wasn't fair. And it wasn't fair that I had this rare disease that not many people knew about. And it wasn't fair that I didn't have anybody to reach out to that knew what I was going through. It wasn't fair. But rather to dwell there in that place, what I decided to do was not to seek out the internet. I decided to seek out individuals and join and align with communities of people that had gone through or were supporting individuals like me. And that's when I found Catherine. And that's when I found Kathy. I aligned myself with people, not the stories of those individuals who didn't survive, but what about the hundreds and thousands of ones who did and now are using their experiences as a platform. Today, this is my platform. Today, this is the day that I let all of you know that there is survival after SCAD. You can make it. You can align yourself with people and doctors. You can partner yourselves with individuals who know about your disease, and you can make it. You can become an advocate. Even if you're just advocating for yourself, even if you're just advocating for the person who you are caring for, you can make it, and you can become a part of those communities. If I had not had SCAD Alliance, I would have believed what the internet said. I woke up every morning thinking, this is the day. This is the day that I'm going to be taken away from my children. This is the day. It's going to happen today. And then I met people who had had many, many tomorrows. Many, many tomorrows. And I'm going to say to you today, align yourself with people who've had many, many tomorrows. Align yourselves with doctors. They are out there. You can go on the SCAD Alliance website. We don't have all 50 states, but we have 25. And an airplane flight
you're worth it. You're worth it. And one of the things I want to encourage you to do today is join support groups. When we were in our group, one of the things that the individuals in our group expressed was the mental part of having SCAD. When I tell you that I woke up every morning thinking that this is the morning that I am not going to make it, what was I doing to myself? It was torment. So every day I thought this would be the day. Every day I'm tormenting myself. You have to practice wholeness. You have to be whole mentally, spiritually, and physically. And in order to do that, you have to have a collective groups of individuals that can address each of those needs. Because this is what we heard today, Catherine. This is what we heard today. The very first thing that came up was this. How can I find someone, connect with someone who understands what I'm going through mentally? When I wake up in the morning and I'm thinking that it's going to be one way and I feel another way, how can I do that? I'm going to encourage you again, visit scadalliance.org. That's what I did. But that's not the only organization. Just within a few minutes, he and I made a connection. So take this opportunity to bond and to talk with the individuals who are around you because you can support each other. And finally, give to the cause. Because these doctors who are here, these people who are speaking to you, they are not individuals who are paid to do it. It is the SCAD Alliance. We're not salaried people. We are people trying to help people. So when you find an organization such as American Heart, SCAD Alliance, all of those, when you find those types of organizations, give to them. Give to them, because when you do so, you're giving back. So this is some of the things that we do. I won't go through those. SCAD Alliance, there's support for survivors, family members. We have our SCAD registry. Did I go? Oh, I went too fast. We have our SCAD registry, online support groups. We have real survivors. And we have downloadable articles that you can download. If you're not sure what to say to a doctor, we have those things that you can use. And you can be, that's an organization that you can give to and know that you're giving to someone that's an organization that is going to help others. American Heart Association, they fund innovative research. We partner with them as well. Advocate for stronger health. They provide life-saving tools, information that prevents strokes, heart attacks, timely, optimal care, all of those things, all of those things that we need. And I had there's the sign there. I won't be able to show you this. But if you want to hear my story or Catherine's story, you should visit our website. I'm not going to play this for you because they're holding the time, but I just do want to encourage you again, advocate for yourself. Believe that there are still great doctors that will do the research. I heard a doctor up here say today that I might not know the answer, but I know how to find the answer, right? But you got to get someone who's open to doing that. And you can lead them. You can lead them to the places that you know they should be. So be an advocate, get involved, join these communities. There are doctors who will do whatever it takes to do no harm. And there are people in this room and people outside of this room that need those types of doctors. So today is your day. You're here for a reason. Today is your day. This day should change your life. Whether you're a survivor, whether you're a caregiver, this day should change your life because today you have received tangible tools to help you move forward. And you're looking at a walking example. I coded for 30 minutes. My brain went without oxygen for 30 minutes. And I am here to tell you that there is life after SCAD. Thank you.
So I'll introduce our next speaker, Rebecca Fallon, who's local. You know, practices in David, North Carolina. She's a psychologist and a resilience coach. And she provides psychoeducation to Atrium patients in cardiac rehab through the Sanger Heart and Vascular Center. And you had in your description that there's the myth of a balance in life. And I'm looking forward to hear a little bit about that too. And the title of the talk is Post-SCAD, Taking Care of Your Whole Self. So thanks for being here. Welcome.
Okay, well, good afternoon. Good to see y'all. Yes, so I am a resilience coach, a psychologist by training, and for the past 10 years or so have been integrally involved with Atrium's cardiac rehab program. So patients who come to cardiac rehab get psychosocial support, psychosocial education, and that is what I do. So through that, I have had access to several SCAD patients over the years. And then I also do some stuff for SHVI in general and have recently, just in the past year, been connected with Dr. Kim, who, as y'all know, is awesome and identifies what acute distress SCAD patients often deal with. And so she connects me with patients very frequently as well, just for some additional support. So what I am going to talk about is some strategies for staying resilient. That's kind of my focus. And I define resilience as going through a difficult time and coming out better or stronger for having gone through it. Resilience is not pretending to be okay when you're not okay. Resilience is not keep going no matter what, keep smiling, keep acting like you're fine. Resilience is being really vulnerable and understanding periods of life are going to test you, but they don't have to demoralize you. And when we look at the research about what differentiates people who continue to thrive even through difficult times, there's some real tangible stuff we can kind of talk about and skills that we can learn to improve our resilience. So this is something y'all have heard about all day and you know it, but SCAD patients often have symptoms of things like depression, anxiety, PTSD even. Tends to be more prevalent in younger patients. The good news is it does get better over time. And I think what is unique to me about SCAD patients is that y'all are typically younger, mid 40s to mid 50s is the average age. That is the busiest decade of life for most women, right? It's when you are perhaps raising family, caring for aging parents, your career, if you have one, is peaking during those years. And so the thing I see most often when I talk to SCAD patients is it is such an identity crisis in a way. It is such a challenge to the way they see themselves in the world. Most of them are previously healthy, and the caregivers, they are the ones who orchestrate care of everyone in their lives. And then they are suddenly thrown into the position of needing the care and being the vulnerable one. And reconciling that and integrating that can really take some time and is a real adjustment for most people who go through SCAD. So one thing we know is that having better resilience scores can reduce psychological distress, or people who are more resilient tend to have less psychological distress. Now, there is a way to measure resilience. There are some, standardized assessments. We're not going to talk about that. We're going to talk about what can you actually do to be and feel more resilient? Because it doesn't really matter what your score is. We want to look at what are you doing to keep yourself feeling resilient. When we talk about stress, we know stress is not good for us. Stress, and you heard it with Dr. Wood's information, I think that was really interesting to look at stressful events often surrounding SCAD. You hear that a lot with heart attacks as well, just regular heart attacks. Not all stress is bad. We have to stop blaming stress for everything. There is actually a good kind of stress to have. Good stress is what we call high demand, high control stress. So think about the stuff in your life that maybe makes you busy, but you enjoy doing that. Like if you have a job that you love, there are periods of time that feel stressful, but I'm good at it. I like it. I know how to do it. That's the kind of stress that kind of keeps you motivated and typically is not unhealthy for us physiologically. Stress becomes toxic for us when that high control changes to low control. So situations that are demanding, they impact your life in a big way, and yet you feel a very low sense of control. SCAD is a perfect example of this, right? At least at first. I feel out of control. You know, patients tell me this all the time. My body betrayed me. I have no idea why or what to do now. I don't understand if it'll happen again. How would I ever know that? It is a huge loss of control, is what I hear from SCAD patients, particularly in those first several months. What's important also with toxic stress, we get sort of this trifecta because often what then shows up is low support, which means that our most important relationships start to break down. If you think about times when you have dealt with high demand, low control stress, it doesn't feel good. You're not in a great mood, quite honestly. You probably don't show up as well as you could for your relationships, whether that's with your husband or your wife or your children or your coworkers. And so the sort of double-edged sword of the whole thing is that our relationships sometimes also start to struggle. And as women, we very much internalize responsibility for that. The ways in which we are not showing up to fulfill all the roles we're trying to play, sister, wife, friend, mother, grandmother. And what I often hear with SCAD patients is a whole lot of guilt and shame wrapped up in that as well, that I'm not able to fulfill the supportive roles in the relationships that I had because I've been living with this toxic stress. So what we're going to talk about is what to then do with this. And what that involves is paying attention to what is beneath your feet. So I use this analogy. I had a client once who was talking to me. He was a rock climber. And he said, you know, one mistake rock climbers make when they're learning is you're trying to get up this rock and everybody reaches for a hold that is just a little bit too high and they end up missing it and they fall. The best way to climb a rock is to look down and look at what is the next little bitty step I could take to make some progress? What is just the next right thing to do? What could I immediately, instead of having these big, you know, esoteric goals about how to be as healthy as I can, let me go back to foundational common sense stuff. What is the next easy thing to do? What could I immediately start thinking about differently or doing differently to take care of myself? What we're trying to achieve is this state of post-trauma growth. This is something that came up in our session today where Maureen was talking about, you know, her experience and how she post-SCAD has renewed appreciation for things, renewed empathy for other people. We hear a lot about post-trauma stress and all the negative stuff that comes out of it, but what happens much more frequently is that after a traumatic event or life experience, people rise to a new level of psychological functioning. You talk to anybody who has been through cancer, heart disease, divorce, losing a loved one, they will tell you some of this stuff. It made me have a new appreciation. It deepened my connection to my spirituality. I value things in my life in a way I didn't. I feel proud now looking back that I navigated that we as a couple got through that trauma, that we as a family navigated that well. We feel proud about that now. So post-trauma growth is the goal. And it's a real possibility, but to get there, we got to focus on some really fundamental stuff. We got to pay attention to what is right beneath our feet. And I use the acronym of EAR in terms of staying resilient. There are three big things we can optimize: energy, attitude, and relationships. All right. So I'm going to give you the high points of these. Energy. Think about your energy. Physical, spiritual, emotional energy is like a bank account. Every single thing you do is either a deposit or a withdrawal into that bank account. Okay. So related to, you know, your physical health, it's important to be real honest about what are the things that drain my energy. Now I think on the website, there's a couple handouts I've provided. One of them kind of walks you through how to think about this. And be real honest with yourself. I hate to use the word should, but a lot of times when we talk about optimizing energy, this is all the stuff. It's like, I know I should or should not do this. When I am the best version of myself, what am I doing? I'm exercising. I'm not drinking too much caffeine. I'm getting enough sleep, whatever, right? Also, I would say what's real important with emotional energy is being really selective about inputs. You know, if the news stresses you out, turn off the news. If there are toxic people in your life, cut them out. That's one thing I hear all the time from heart patients. Like, one of the benefits of this is I got real clear on who I needed in my life and who I did not. And I don't know if I would have done that, right? Those are energy drainers. What we want to do is maximize the energy boosters, the things that, or the people that make you feel uplifted, or the activities or the things you do to take care of your spirit, mind, body, all of it. So we want the deposits to drastically outweigh the withdrawals. One thing to know about human performance is that most of us perform pretty well when we are stretched just a little bit beyond what we think we can handle. That's our target zone, right? So, you know, you have a busy day and you got just enough going on that you kind of get super efficient and knock it out. The problem is it's a real short walk from that target zone to the place where we get overextended. Like if I added 3 more things on your list for today, or you run pretty well on, 6 hours of sleep and you get adrenaline, but if I gave you 4 nights in a row of not enough sleep, you're in that fatigue space where you're not making good decisions and really running the risk for exhaustion and burnout. This is, for women, we all need to pay attention to this, because every woman I ever talk to says, and we talked about it in our group today, I just do well when I'm busy. So you know what? I just stay busy. I just got right back to it because I want to be distracted. I want to be too busy to really think about what's going on with me. And recovery from SCAD requires more self-compassion than that. It requires that you stop and you pause and you let yourself rest and heal and stop trying to be all things to all people. There is a real myth of balance. It is impossible to balance everything at once. The word balance in itself is problematic. Balance means everything's getting equal weight at the same time. You know that's not true. You're never doing everything equally at the same time. If you're trying to take care of yourself, have a marriage, raise some kids, maybe work outside the home, see your parents, whatever, all the roles we try to play, there's no way to balance it. And we need to give ourselves more grace around that concept. So another really important thing to pay attention to related to energy is, what are your stress symptoms? One of your handouts is also a list of stress symptoms that fall into these 5 categories. We all have different, my stress symptoms are different than yours. I'll get physical symptoms you won't. I'll engage in some thinking patterns that you don't. And so it's really good to stay aware of your specific symptoms of stress as kind of a clue that that energy balance, that deposit withdrawal scenario has kind of gotten out of whack, okay? The A is for attitude. Thing about attitudes, you need to ask yourself, what am I thinking and therefore spreading? Because attitudes are contagious. You know this. Think about people you love to be around. It's because they walk in the room, they have good attitude, they have good energy, right? Think about people, Debbie Downer, who walks in the room and sucks the life out of it. That is also contagious, right? We got to take responsibility for trying to cultivate resilient attitudes. 2 really important ones for heart patients in general are incorporation and realistic optimism. When a life-altering event happens, you can tell yourself a story of either disruption or incorporation. A story of disruption is, my life was great, and then this happened, and now that's it. Nothing's ever going to be the same again. A story of incorporation is, my life is about a lot of stuff. My life is complex and messy because people are complex and messy. And this chapter that I am writing right now, I was not expecting to be writing, but the book is going to continue. There's a lot of good stuff still to come, as we just heard. There is life after SCAD. There are chapters to be written. And if I can maintain a story of incorporation, I'm able to also stay realistically optimistic. Now, realistic optimism is important. This is not rose-colored glasses. This is not everything is always great and it's always going to be great, and that's all I'm going to say. Realistic optimism is I am realistic about what is challenging for me right now, what might stand in my way, the stuff I'm not doing right, but I also maintain a really strong sense of hope that it's going to work out. So it's not cynicism, it's being realistic and also staying hopeful. And we know, particularly with health challenges, optimism is incredibly important in predicting good outcomes. So most of us are not naturally optimistic. So you got to work at it. You got to try. You got to look for the good. Our brains are kind of wired for negativity. Last is relationships. Now, we could talk about relationships all day long, but going back to the thing I usually hear from SCAD patients is trying to be all things to all people. And as we get rid of this myth of balance, balance is not the goal. The greatest gift you can give anyone, including yourself, is your full attention. Think about what a rare commodity that is these days. You very rarely give your full attention to anything. We spend almost half our lives in a state of distraction. We are constantly looking at phones. We are constantly, and I'm as guilty as anybody. I feel terrible for this generation of children we're raising who are looking up at a generation of adults who are constantly doing this. Even when we say we're listening to their story or we're watching their ball game or whatever, we're very rarely fully present. What I encourage you to think about is that balance is not the goal. Don't seek balance. What we want to seek is purpose, meaning, and engagement. We can do anything if we feel like it's meaningful. We can do anything if we decide there's a purpose to this for me. There's a purpose to this journey, and I'm going to let myself be fully engaged. And this applies to you taking good care of yourself. When you look at the energy stuff, when you get real purposeful about how am I going to feel better? What are the things I need to recommit to? And do it with full engagement. Do it without this guilt of, if you decide I got to start exercising, I need to do cardiac rehab. What I hear all the time from people is, yeah, but then it's going to take me away for X number of hours. And, so-and-so needs me and so-and-so needs me. And of course they need me. You also need you. You need your full attention right now. During times of stress, during times of recovery, you need to be fully engaged in practicing compassion for yourself because this is an unprecedented thing. Very few people go through the journey that you have been on thus far, and you need to give yourself the grace to be present for yourself in that journey. So balance is not the goal. Engaging is the goal. Think of the analogy of a rushing stream. If I told you, okay, you got to get across this stream and the only thing in the water is some rocks here and there. You know good and well the only way to do that is to decide where you're going. Pick a rock. Get your balance on that rock until you decide, okay, now it's time to go to this rock, and then get present and firmly plant your feet on that rock. If you've got one foot on this rock and you're kind of going, oh, I should have gone that way, or maybe I'll go here next, you're going to fall, right? The same applies when we get too stressed and we lose sight of the value of engagement. Nothing is going to work out well. We're going to feel scattered and chronically stressed and overwhelmed. So as you navigate this journey, I think there's been such incredible information today about support. Support is so important. The thing that I hear often from SCAD patients that differentiates them from other heart patients also is how lonely this journey can feel because it is such an identity rattling event. It happens at an inopportune time in life and you don't feel like you got a lot of support or a lot of peers. So I encourage you, number one, to be generous with the support that you are able to offer others. Whatever you can do to connect. SCAD Alliance is incredible, as y'all have heard all day long, but we're going to all tattoo it on our foreheads. We need to be looking there. We need to be spreading the word. We need to be generous in spreading the knowledge we've gained today with other people and be gracious. And when I think being gracious, I think we sometimes think that means being polite, but I really mean be gracious with yourself. Give yourself endless compassion and patience and grace as you navigate this. Okay? That's it. Thank you.
I also really like that concept of stretch versus strain and the metaphor going off the edge a little bit. And I think that was a really good segue for the next talk because migraine is the most common, debilitating symptom that SCAD patients experience. And a lot of this starts with taking care of yourself, right? So we'll talk about some of the medications and the epidemiology and things like that too, but not to underestimate. The most important thing is, especially after your event, taking care of yourself, prioritizing life, thinking about what fills your cup and what drains your cup, and all those things that were just emphasized are really important, or you'll be more likely to experience migraines and headaches. So that's what we're going to talk about today. My only disclosure is that I'm not a neurologist. So there are some situations where we refer to an expert neurologist for headache management, and that's okay. But I'll teach you everything that I know from a cardiovascular perspective. So here are the objectives: to know the definition of a migraine headache, understand that migraines are a common symptom, and actually the most symptom that SCAD and our other arteriopathy patients experience, and learn treatment strategies for SCAD patients who experience migraines. So this is a typical case of a 42-year-old woman who has migraines. She developed chest pain for 2 to 3 days. Her blood tests were abnormal and she had a heart catheterization. She didn't have any other significant medical history or smoking. Pregnancy test was negative, and she had a heart catheterization. Have you seen a few of these angiograms today? Okay, just a few? Okay. Can you see that where the vessel narrows there a little bit? And the distal, that's called the circumflex artery. So this patient was having a SCAD, and her only risk factor or other medical condition was the migraine headache. So that's her SCAD and her circumflex artery there. And you could see the narrowing, and then it kind of reconstitutes flow distally. But that was a SCAD event. And you may have seen a slide like this. This is kind of an introductory slide that SCAD is non-iatrogenic, non-traumatic. So it's not induced by a catheter or any other sort of procedure or manipulation, but it can occur in up to 1 to 4% of heart attacks or chest pain patients. The average age is 40 to 53 years old, and you see the bell curve age distribution there. And it's a common cause of pregnancy-associated MI, and the recurrence is 20 to 25% at 5 years. But we keep seeing that going down with some of the medical therapy and knowledge that we've gotten due to with some of the physician scientists you've met today. And you saw this slide with Dr. Wood as well. But there are predisposing conditions, so precipitating factors, and you can see on the right-hand side, emotional stress and perceived stress scale. Those are really, really high, and those are patients who might be experiencing migraine headaches as well. So these were predisposing risk factors that were occurred prior to the patient's SCAD event. And again, there's some type of, it's more common to have a type A personality or a higher perceived stress scale in patients with SCAD. And this, have you seen this diagram yet today? Some of our slides are from some of the common publications, but this is a really good figure with SCAD in the middle. Okay, it's called a Venn diagram, right? And you have fibromuscular dysplasia, which you've heard about, other arteriopathies or disorders, connective tissues, some genetics that you've heard about. And if you go all the way around the circle, there's an association with migraine and emotional stress. And that's what we're talking about today. And we don't know exactly how they're linked, but we have found some genetic associations between both migraine headaches and spontaneous coronary artery dissection. So what's the definition of a migraine? Who all experiences migraines or headaches? And so that looks about right, about half the room. Are we on video, by the way? Am I on video or is the audience? Well, it's just kind of funny because if looking at you guys, it looks like half of you are drinking Michelob Ultras. So I love that. If we take a picture, that might look really awkward, but I can't get used to the new water bottles. But so the definition of migraine is that you've had at least 5 episodes, and those episodes last 4 to 72 hours. This is the International Headache Society definition. There's a criteria. There's other types of headaches too, but you may experience something that's unilateral, pulsatile, moderate to severe intensity. So it's either triggered or exacerbated by physical activity, ADLs, and things like that impact your quality of life. And also, you may have nausea, vomiting. What's photophobia and phonophobia? Anyone know what that is? It's when the light bothers you, and you want to go into a dark room and turn off the lights and be real still and quiet. And then you can have it with or without aura. So there might be some type of sensorium, like an unusual vision or smell or something that you know that headache or that migraine is coming on. So that's the definition of a migraine. And not every headache is a migraine, but these are the most common types in patients with these vascular disorders. And we know they're associated with an increased risk for cardiovascular events. And it's the most common symptom in SCAD, and it's the most debilitating, right? It affects your quality of life. 37 to 46% of patients compared with the general population of women, which is approximately 24%. And so if you kind of rearrange that Venn diagram, we're talking about migraines, and there's associated with arteriopathy. One of the most common arteriopathies is fibromuscular dysplasia that you've heard about, other connective tissue disorders, and SCAD. So these are some of the publications that we've worked on. Fibromuscular dysplasia, you probably heard it's the most common underlying vascular condition that can predispose people to a SCAD event, correct? So there's clearly a relationship with there, but these are the headache data from the FMD registry that 2/3 of FMD patients experience some type of headache, not necessarily migraines. And among those, more than half experienced migraine type headaches, and many of them were frequent. So daily or weekly headaches. So very debilitating. And it was associated with a younger age. Some of these other symptoms, dizziness, pulsatile tinnitus, which is a whooshing sound you can have in your ears from the carotid artery involvement. And it's more common if you've had something like a carotid artery dissection or an aneurysm in around that extracranial or intracranial carotid area. And it's more associated with depression. Okay. So that's for that. Those are the data. That's what we know for fibromuscular dysplasia. And these aren't our iSCAD data, which we're working on the publication now. These are data from 2018 from the Mayo Clinic Registry. This is SCAD and migraine. So the lifetime prevalence was 40%. So not quite as high as FMD, but still pretty high. And again, the most common symptom. Majority of these patients had fibromuscular dysplasia. And among patients with SCAD, it was more common to have depression if you had migraines, and it was more common to have recurrent chest pain if you had migraines. So again, it gets back to really, really taking care of yourself, prioritizing sleep, wellness, and addressing those symptoms that all impact your quality of life. So there is clearly an association there. Distribution of SCAD patients with migraine. You can see from this curve that the purple bars are all patients without migraine, and then the blue is with migraine. And you can see the blue patients have their SCAD at a slightly younger age. So maybe the average is around 45 to 50 for all comers, and then you shift that to the left, five or so years younger. So more likely to present at a slightly younger age if you have migraine headaches. So it kind of speaks to the severity of the disease. Fortunately, migraine didn't predict recurrence of SCAD. So these bars pretty much overlap statistically. So there's no statistically significant difference in recurrence of SCAD between patients with migraine versus without. So that's good news. And these are from the iSCAD registry. These are one of the abstracts that we presented at the American College of Cardiology, and we're working on the manuscript now. So 45% of the patients from our registry among the first 452 had migraines. Those with migraines are more likely to be women, and again, had higher rates of depression and anxiety. So it does go together, and we see that with a lot of chronic conditions where it impacts the quality of life, and there's that higher incidence of depression and anxiety. Migraine frequency was approximately half. You could see from that pie chart there, approximately half of patients may be having headaches monthly or more frequent. Fortunately, the 57% were less than monthly. Okay, so in things that contribute to a SCAD event, the commonly associated conditions are to your right. So again, fibromuscular dysplasia and migraines up there too. So it's a really, really common symptom. We always ask about this, not necessarily a risk factor. One doesn't cause the other, but it's the most common association. Also the cervical artery dissection and FMD involvement. And there's probably a genetic link here, as you can see in the middle of the screen, contributing to that SCAD event. And here are some of the genes we're aware of. You don't really have to know the genes. Did anyone do a full talk on the genetics today? So you've probably heard of some of these. just know that we're, in simple terms, these genes are not diagnostic for SCAD or FMD specifically, but they're markers of risk. So in patients that have had an event, they're more likely to have a abnormality in one of these genes. And that first one was the most novel. It's called factor with a pH, right? So actin regulator gene, and that's really, really important because you can see all the things that it's associated, the kind of links a lot of the conditions and symptoms that we're talking about. So cervical artery dissections, hypertension, headaches, and a lot of those patients has SCAD as well. So factor is that one that we're looking at. And these could be later on in the future, hopefully help us with diagnosis, risk stratification, and maybe treatment like a medicine in the future. So we're just starting to learn about some of these genes and what to do with them. There's a few others. There's COL5A1, which is actually a gene that's associated with classic Ehlers-Danlos syndrome. And then that LRP1 gene is a locus or a focus for migraines and SCAD as well. So a lot to learn there. We've made a lot of progress, especially in the last few years, thanks to you all's support. So treatment. So there's no established guidelines for treatment of headaches with SCAD. We generally treat headaches and migraines similar to that which we would for a non-SCAD or FMD patients, with one exception, and that's the third line, the vasoconstrictors, right? So you want to avoid Imitrex specifically, right? Or other types of medications that would constrict the arteries or narrow them. So there are other over-the-counter, such as Sudafed, for example, right? Or maybe an ADHD medication, and Imitrex is one too. They all constrict the arteries and can worsen your headache or your blood pressure, right? Okay, and put strain on the blood vessels, and we want to avoid that. And again, you just heard a great talk about emotional risk factors, so triggers, so alcohol, smoking, other emotional stressors or triggers, really doing the best that you can to focus on yourself and fill your tank as much as possible, so to speak. Okay, and one good thing is that we see that migraines tend to improve after SCAD. It's probably because a lot of patients are placed on beta blockers, and that's one of the prophylactic treatments that can reduce the frequency and severity of migraine headaches as well. There's a relatively new medication called a CGRP inhibitor, or calcitonin gene-related peptide. Those have been a remarkable advancement in neurology and headaches because they can significantly improve frequency and severity of headaches for prophylactic treatment, but also an abortive treatment. Again, I mentioned that the Imitrex wasn't a good idea. The CGRP inhibitors can be an abortive treatment as well. So now we have more options. And the message here is that we have a lot of options, and it's kind of, sometimes it's trial and error. We don't know who's going to respond favorably to which medication. So don't get complacent or don't get discouraged if one medicine doesn't work, because there are a lot of options. Go back to your cardiologist and go back to your neurologist and keep trying different medications, and likely one of them will work. And some of you probably have experience with some of these medications. They all have slightly separate indications and side effects, but this is a pretty comprehensive list of things you should try. So prophylactic on the left-hand side of the screen, those are for people generally that have headaches or migraines more frequently than 4 times a month. That's when we usually start to consider these medications. Again, a lot of patients are already on beta blockers, so that's really, really helpful. There's antidepressants that help and anticonvulsants, like seizure medications that can help. I mentioned the CGRP inhibitors. For some people that continue to have severe headaches, they've tried botulinum and the injections in the neck area, and that can help treat the headaches occasionally. Magnesium and riboflavin, those are like vitamins you can get over the counter. Magnesium, we've had really good results with, anecdotally, significantly improves quality of life. And it's what you would think. It's like the vitamin magnesium. You can take 1 or 2 a day. Don't take too much, because do you know what the side effect of magnesium is? Yeah, don't take too much. You may get loose stools, but taking 1 a day hopefully can decrease the frequency of your headaches. And on the acute side, so when you have a worsening migraine headache, you have to be careful about the Imitrex, so that's one to avoid. But start with a less potent medication, then increase if needed. So acetaminophen first, maybe an NSAID if needed. And again, an antiemetic can help significantly improve your nausea. Those are the nausea medications and the CGRP inhibitors. If you go to the emergency room, if it's a severe headache, they may treat you with similar medications, but an injectable form. But those 4 medications that I listed are ones you could take at home as well. So this is a nice algorithm that was in, again, the prior SCAD a migraine document of how to manage patients with respect to their migraines after a SCAD event. So the first line is when the patient's in the hospital. So address headaches, educate on headaches, and address any medications that contribute, worsen headaches, just a comprehensive review and some education. Okay, and then at our first clinic visit, hopefully we've reevaluated, probably you're on a beta blocker, and we kind of reassess, are there any headaches? How frequent are they? Are they improving? Again, is there anything we can do that's non-pharmacologic that may help? And if they are more severe and more frequent, again, the greater than 4 times a month is kind of a rough cutoff, then we'll refer to neurology and consider some of those other prophylactic medications that I mentioned on the list. Okay. Another thing I wanted to mention is when should you seek further medical attention? So imaging would mean like maybe you need a CAT scan or an MRI of your head, depending on the symptoms. And it doesn't mean you have to rush to the emergency room necessarily, but you should be maybe calling a provider if one of these things happens, right? This might be a red flag. So you need to let someone know and see if it's okay or you need further evaluation. So if it's the first or the worst headache of your life, if there's a change in frequency or severity of the pain, like an acute change, some newer unexplained neurologic symptoms like a focal weakness or numbness in a certain area of your body. And those could be a worsening migraine that needs to be treated, but also again with the blood vessels being fragile, that could be a concern for something like a dissection or an aneurysm. And those are things, again, that if we see any red flags that we'd want to make sure is not occurring. Some of the others are with respect to the cancer and the HIV infection. If you're immunosuppressed, you might be at higher risk for having an infection in the cerebrospinal fluid. So that's what that is describing there. Same thing as the fever, stiff neck, and papilledema. Okay, those could be meningitis signs and symptoms, but some of those top few, if you experience those symptoms, definitely let your provider know. Okay, so migraine is the most common symptom in SCAD. Almost half of the patients will experience that. And it has the most impact on your quality of life. It's probably the most debilitating symptom. So I would address it and focus on all the pharmacologic and non-pharmacologic interventions that we discussed to improve your quality of life as much as possible. It's associated with depression. It's unclear what the cause is. Migraines are really complex in terms of the etiology and the pathophysiology at a scientific level. So we don't really know, but we definitely know that there's an association with vascular disease and vascular abnormalities, and we're just starting to learn about the genetics of it. And again, the treatment's generally the same, except we're avoiding the vasoconstrictors. So hopefully that was helpful for you. And we have a few minutes for questions, and then you're on a break.
Can you repeat what you said about the Sudafed, ADHD, Imitrex?
Yes, there's that is the relationship between those types of medications is that they're considered vasoconstrictors. Okay, so those are medications that narrow your arteries. That's their mechanism of action. That's how they are supposed to work. But that can put stress on your blood vessels and increase your blood pressure. And those are things we try to avoid in patients with vascular conditions. So those are a few examples. Those are some of the common ones that we ask about. There are probably others too, like a recreational drug might be cocaine. That's kind of the most extreme version, but these are similar mechanism, but less potent. Yes. Caffeine, good question. So how much caffeine is safe? So caffeine in moderation is okay. Everybody's different, but 1 cup a day, maybe 2 at the most. But I would stay away from Monster, Red Bull. My son recently informed me there's a drink called Prime. Can I tell you all a secret? Don't promise you won't tell anybody. This is like a parenting fail, and you may have to give me some advice after this. So there's this drink called Prime. It's like an energy drink. And my 7-year-old son wants to get it from the gas station. So I think it's like a Gatorade or something like this. So I take him in and we look for the Prime. Fortunately, they didn't have it, but I was mentioning it to my nurse the next day because I was trying to impress her that I knew the cool energy drink on the block. And she's like the reference standard for all things cool. But I put my foot in my mouth. She said, "Isn't that the one that's unsafe for kids?" And I searched it on my phone, and the first thing that comes up is not recommended for children under age 18. So it turns out it has like 200 milligrams of caffeine. So we have a new rule in the house that no prime for kids. So, and no prime for SCAD patients. So yeah, so I would, moderation's okay. So a cup of coffee, for example, but definitely something to be mindful of. Up here.
You mentioned the CGRP inhibitor. If you know that your migraines are probably caused by barometric pressure, is that one that would be helpful for that or not?
That's a good question, and a specific one, like with travel or weather and things like that. I don't know specifically. That's a good question, but I would look into it. That's again, with that's relatively new, so I haven't seen that as a specific indication because there are various triggers.
Okay.
One of them may be barometric pressure. Some can be sleep or stress and other triggers. I would generally think yes, if it's a typical migraine, like we said with that definition, there's a good chance that it'll help. I don't know about that specific trigger because there are various triggers.
Okay, and then I have one more question.
No, one question per person. Sorry.
Oh, sorry.
Go ahead.
FMD, I've heard some buzz that we're not supposed to use NSAIDs, but yet my doctor is fine with me using using ibuprofen when necessary, not to, use it very much, but just use it when I'm really, it doesn't really help the headaches, but it did help when I had pleurisy. So what are the thoughts on that as a whole?
That's been my recommendation too, is that you shouldn't take NSAIDs regularly, and we try to avoid them if possible, but it is okay to take rarely when needed. So the recommendation for a headache might be, or any type of pain, take a Tylenol first. You can take up to 4 grams of Tylenol per day safely, and as long as you don't have a liver problem. So that's 8 500 milligram tablets. You don't have to, but you can safely. If a few acetaminophen don't work, then move on to the NSAID. Again, use that sparingly, but that's safer than something like an Imitrex. So that would be the second medication that I would take sparingly for pain like a headache. Yes.
I've heard in the SCAD survivor community, connections to chest pain and migraine, like the after SCAD chest pains, associated with different phases in their menstrual cycle.
Yes.
And then there's also people that haven't had a SCAD that have migraines at those same times. Have you noticed any connection?
Yes, we have. So the question about the association between all types of pain, such as chest pain and as well as headaches with migraines, we call the medical term for that's catamenial, meaning it's with your cycle. And that's a real thing, and it's probably a hormone surge. And in general, the treatment might be the same. So you might want to address the cycle first, see if there's anything that's affecting it, but it's not uncommon at all to have various types of chest pain that are related to the cycle. And it could be that you can anticipate that and take a medication at a certain point in time to try to prevent it, or change something with your schedule. But absolutely, there's not a specific therapy though for catamenial pains, but there's clearly a relationship there, and it's there's still a lot to learn about why and how it's related to hormone surges. It's true.
And for the people who have those same symptoms but have not had a SCAD, have you seen any correlation that it could be like an indicator of a future SCAD?
I have not, but that is a good question. We haven't seen that as a predictor. So in retrospect, did this patient have catamenial pains? Bless you. But right, migraines, yes, but not necessarily catamenial, but related to the cycle. But migraines, with some of the data we presented, migraines, regardless of the trigger and the type, we don't know specifically. They can. Not that we've seen specifically, but I don't know if we've had enough. We have not looked at that specifically, and anecdotally, I haven't seen that. But it makes sense from what we know in terms of our suspicion with the relationship with hormones that might be a relationship.
Would it be something worth, if you're a SCAD survivor and you have daughters, for example, and they have the similar migraine profile, is it worth treating in any of these ways?
Right.
preventatively, potentially?
I think so. So, and we know a little bit more about the familial relationship with fibromuscular dysplasia, for example. So there might be, so if you have FMD, there's a 10% chance you have a family member with FMD. And so we don't recommend screening everybody, like doing those CAT scans on it and that type of thing. But if someone has signs or symptoms that are concerning of an arteriopathy, that would lower our thresholds to start to maybe think about diagnosing or evaluating further, and maybe being cautious with some of the other preventive tools that we discussed. So that, yeah, so for me and most of us, that would lower our threshold for looking into that a little more closely. And again, common symptom for those, the common questions to ask would be migraines, pulsatile tinnitus, hypertension. Those would be common questions that we ask, and a lot of the flexibility, hypermobile questions that we ask as well. But those, unfortunately, those are common symptoms for all adults, but those are specific questions that we do ask that could have a signal. And I think we're done. I'll stick around for a few minutes in case anyone has any questions.